بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء وأطهر المرسلين نبينا محمد وعلى آله وصحبه أجمعين. صاحبة السمو الملكي الأميرة الدكتورة نوف بنت الحسن آل سعود، سعادة رئيس الجامعة الأستاذ الدكتور صالح بن عبد الله المزعل راعي هذا الحفل، أصحاب السعادة، ضيوف الجامعة الكرام، المشاهدين والمشاهدات عبر النقل المباشر لهذا الحفل، السلام عليكم ورحمة الله تعالى وبركاته. وبعد، في بيئة علمية تعيد اليوم تعريف دور الجامعات، لم يعد البحث العلمي غاية معرفية فحسب، بل أصبح أداة استراتيجية لصناعة القرار وتحسين جودة الحياة ورفع كفاءة النظم الصحية. ومن هذا المنطلق تأتي جامعة المجمعة وهي ترسخ موقعها كمؤسسة أكاديمية فاعلة تربط المعرفة الطبية بأثرها الواقعي على الإنسان والمجتمع. ويأتي انعقاد المؤتمر الدولي الثاني للسكتة الدماغية ليجسد هذا التوجه من خلال تناول أحد أكثر التحديات الصحية تعقيداً وتأثيراً، وهو تحد تتقاطع فيه مختلف العلوم. أيها الحفل الكريم، ومن هنا يكتسب هذا المؤتمر أهمية بوصفه منصة علمية لمناقشة أحدث ما توصلت إليه الأبحاث واستعراض التجارب الدولية وبناء جسور تعاون تسهم في تطوير البروتوكولات العلاجية. أيها الحفل الكريم، يشرفنا نستمع الآن إلى تلاوة عطرة من آيات الذكر الحكيم، يتلوها علينا الطالب بدر بن مقرن العبد المنعم من كلية الشريعة والقانون.
أعوذ بالله من الشيطان الرجيم. أقم الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك ربك مقاما محمودا وقل رب أدخلني مدخل صدق وأخرجني مخرج صدق واجعل لي من لدنك سلطانا نصيرا وقل جاء الحق وزهق الباطل إن الباطل كان زهوقا وننزل من القرآن ما هو شفاء ورحمة للمؤمنين ولا يزيد الظالمين إلا خسارا.
أيها الحفل الكريم، تأتي رعاية هذا المؤتمر في تأكيد واضح على إيمان الجامعة بأن دعم البحث العلمي النوعي وتمكين الكفاءة العلمية يمثل ركيزة أساسية في تعزيز دور الجامعات في التنمية الوطنية الشاملة. نستمع الآن إلى كلمة سعادة وكيل الجامعة للدراسات العليا والبحث العلمي الأستاذ الدكتور محمد بن عبد الرحمن الشهري.
الحمد لله رب العالمين. الحمد لله القائل: ومن أحياها فكأنما أحيا الناس جميعا، والصلاة والسلام على نبينا محمد وعلى آله وأصحابه أجمعين. صاحبة السمو الملكي الأميرة الدكتورة نوف بنت الحسن آل سعود، سعادة رئيس الجامعة الأستاذ الدكتور صالح بن عبد الله المزعل، أصحاب السعادة كل باسمه ورسمه ومنصبه، أيها الحضور الكريم، السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني في هذا الصباح الجميل أن أرحب بكم جميعاً في رحاب جامعة المجمعة في افتتاح هذا المؤتمر الطبي الفريد، حيث نعبر عن بالغ سعادتنا واعتزازنا بتنظيم هذا الحدث العلمي المتميز الذي يحمل رسالة سامية وأهدافاً نبيلة، ويشكل منصة علمية رائدة لتلاقي أفكار الباحثين والمتخصصين في مجال السكتة الدماغية. إن تنظيم مؤتمر جامعة المجمعة الدولي الثاني للسكتة الدماغية يجسد التزام الجامعة بتعزيز مسيرة البحث العلمي ودعم التطوير والابتكار بما ينسجم مع الأولويات الوطنية ويسهم في تطوير منظومة الرعاية الصحية في وطننا الغالي. كما يعد هذا المؤتمر فرصة علمية لاستعراض أحدث المستجدات والتطورات في مجالي الوقاية والعلاج من السكتة الدماغية، مع التركيز على الدور المحوري للبحث العلمي والابتكار في تحسين جودة الخدمات الصحية. ويتميز هذا المؤتمر بمشاركة علمية واسعة، حيث يضم أكثر من 25 متحدثاً من الخبراء والمتخصصين من المجال الصحي والأكاديمي والبحثي، يناقشون موضوعات مختلفة خلال 6 جلسات علمية على مدار يومين. وقد بلغ عدد المشاركات العلمية أكثر من 40 ورقة علمية، وبلغ عدد المسجلين لحضور جلسات المؤتمر ما يزيد على 1000 مشارك. أيها الحضور الكريم، ويأتي تنظيم هذا المؤتمر متواكباً مع الرؤية الطموحة رؤية المملكة 2030، حيث تفخر جامعة المجمعة بأن تكون شريكاً فاعلاً ومساهماً في المبادرات الوطنية التي تهدف إلى مواجهة التحديات الصحية وتطوير التقنيات والحلول المتقدمة المرتبطة بالسكتة الدماغية. وفي الختام، لا يسعني إلا أن أتقدم بجزيل الشكر وعظيم الامتنان لسعادة رئيس الجامعة الأستاذ الدكتور صالح بن عبد الله المزعل على رعايته الكريمة لهذا المؤتمر ومتابعته المستمرة لأعماله. كما أتقدم بخالص الشكر والتقدير للراعي الماسي مصرف الراجحي ولكرسي الشيخ عبد الله التويجري على دعمهما الكريم وإسهامهما الفاعل في نجاح هذا المؤتمر. ويمتد الشكر والتقدير إلى جميع ضيوفنا المتحدثين وإلى كافة الجهات المشاركة من داخل الجامعة وخارجها لما قدموه من تعاون مثمر ومشاركات نوعية أسهمت في إثراء محاور هذا المؤتمر. ولا يفوتني كذلك أن أعبر عن بالغ الامتنان لكافة اللجان الإشرافية والتنظيمية والعلمية على ما بذلوه من جهود مخلصة وعمل دؤوب كان لها الأثر الكبير بعد توفيق الله تعالى في تنظيم هذا المؤتمر وإخراجه بالصورة المشرفة. وأجدد ترحيبي بكم جميعاً باسم جامعة المجمعة ومنسوبيها، متمنين لهذا المؤتمر النجاح والتوفيق وأن يحقق أهدافه العلمية والإنسانية. وآخر دعوانا أن الحمد لله رب العالمين، والسلام عليكم ورحمة الله وبركاته.
أيها الحفل الكريم، ندعو الآن صاحبة السمو الملكية الأميرة الدكتورة نوف بنت الحسن آل سعود، رئيس مجلس إدارة الجمعية العلمية السعودية للصحة الوقائية، لإلقاء كلمتها بهذه المناسبة.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. سعادة رئيس جامعة المجمعة، أصحاب السعادة، السادة العمداء، الزملاء والزميلات، الضيوف الكرام، السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني أن أفتتح الجلسات العلمية لليوم الأول لمؤتمر جامعة المجمعة الدولي الثاني للسكتة الدماغية، وأنا أتقدم بخالص الشكر والتقدير لجامعة المجمعة على هذه الدعوة الكريمة والتنظيم المتميز الذي يعكس رؤيتها العلمية الطموحة. إن هذا المؤتمر نموذج مشرف للتعاون المبارك بين الجامعات السعودية وتكامل الجهود البحثية لمواجهة أحد أهم التحديات الصحية، حيث تمثل السكتة الدماغية أولوية وطنية ذات بعد وقائي بالغ الأهمية. تؤدي الجمعية العلمية السعودية للصحة الوقائية دورا محوريا في هذا المجال من خلال تعزيز الوقاية الأولية والثانوية ودعم البحث العلمي ونشر الوعي بعوامل الخطورة القابلة للتعديل، والعمل مع شركائنا الأكاديميين والصحيين لتحويل المعرفة إلى سياسات وبرامج وقائية فعالة تسهم في تقليل عبء السكتة الدماغية وتحسين جودة الحياة، بما يتماشى مع مستهدفات رؤية المملكة 2030 في تعزيز الصحة الوقائية. كما نعتز بالإنجازات النوعية لمنسوبي جامعة المجمعة داخل الوطن وخارجه، والتي تعكس تميز الكفاءات الوطنية وحضور المملكة المشرف في المحافل العلمية. وختاما، نؤمن أن الوقاية ليست خيارا صحيا فحسب، بل مسؤولية وطنية مشتركة، وبالعلم والشراكة نصنع الفارق ونحمي الحاضر ونبني مستقبلا صحيا أكثر أمانا لوطننا الغالي. والسلام عليكم ورحمة الله وبركاته.
جامعة المجمعة خطواتها الراسخة في مجال الاعتماد الأكاديمي
التي تنظمها جامعة المجمعة انطلاقا من استراتيجياتها لأن تكون رائدة في البحوث العلمية والابتكارات النوعية.
نؤكد التزامنا التام بتعزيز مسيرة البحث العلمي والتطوير والابتكار.
إنني اليوم أقف وأنا أحمل كل مشاعر الفخر والاعتزاز لانتمائي لهذا الصرح العلمي.
ربما لم يتفوق عليها أحد أو في موازاتها. نسبة الامتثال بلغت في هذه الجهة 98.20%.
كانت الجائزة الكبرى من نصيب المبتكر السعودي الدكتور سعد العنزي من جامعة المجمعة.
يعجبني والحمد لله في هذه الدولة وفي هذا الشعب طموح المستمع، بحيث ما يرضينا دائما ما وصلنا إليه وما نصل إليه، بل نطمح أكثر، وهذه نعمة من الله عز وجل. هل نكتفي بذلك؟ هل نركن ونقول عملنا كل شيء وصلنا القمة؟ لا.
ومن هذا الطموح كانت البداية، ففي 3 من شهر رمضان عام 1430 هجرية تأسست جامعة المجمعة، ومنذ ذلك الحين ولأكثر من 16 عاماً وهي تواصل البناء والتطوير. وخلال هذه السنوات شهد البحث العلمي في جامعة المجمعة نمواً متدرجاً ومتسارعاً تجلى في زيادة الإنتاج البحثي وتنامي النشر العلمي وحضور متقدم في قواعد البيانات العالمية. ولم يقف هذا الأثر عند حدود القاعات البحثية، بل امتد من الداخل الأكاديمي إلى الأثر الخارجي، حيث تترجم المعرفة إلى مبادرات وتتحول الأبحاث إلى تطبيق يخدم المجتمع. ومع كون السكتة الدماغية من أبرز أسباب الوفاة في المملكة، كان لجامعة المجمعة دور فاعل في تحويل المعرفة العلمية إلى مبادرة وطنية مؤثرة. وفي هذا الإطار نظمت جامعة المجمعة المؤتمر الدولي الأول للسكتة الدماغية بحضور أكثر من 1000 مهتم من المختصين في المجالات الصحية والبحثية إلى جانب الطلاب، وبمشاركة 21 متحدثاً، وتقديم 16 ملصقاً علمية ضمن 6 جلسات علمية، وبمشاركة أكثر من 40 جهة. واليوم تتواصل هذه المسيرة بانعقاد المؤتمر الدولي الثاني للسكتة الدماغية بمشاركة 26 متحدثة وأكثر من 60 جهة، إلى جانب معرض علمي يستعرض المبادرات والابتكارات في إطار علمي يعزز الأثر الصحي والمجتمعي. جامعة المجمعة، طموح لا يتوقف.
أيها الحفل الكريم، يسرنا في هذا الأثناء ندعو راعي هذا المؤتمر سعادة رئيس الجامعة الأستاذ الدكتور صالح بن عبد الله المزعل للصعود للمسرح للتكريم. درع تذكاري مقدم من جامعة المجمعة إلى صاحبة السمو الملكية الأميرة الدكتورة نوف بنت الحسن آل سعود. وتقديراً للدور الريادي في دعم المبادرات العلمية والصحية، وتقديراً لرعاية هذا المؤتمر، يسعدنا تكريم مصرف الراجحي الراعي الماسي لمؤتمر جامعة المجمعة الدولي الثاني للسكتة الدماغية. نأتي الآن لتكريم متحدثين لليوم الأول، وهم الأستاذ الدكتور هارون بن فياض شودري، الأستاذ الدكتور عبد العزيز بن محمد العثمان، الدكتور سعيد بن صالح الزهراني، الدكتور محمود بن عبد الله الشنقيطي، الدكتورة حنان بنت عبد الرحمن الحازمي. الدكتورة ابتهال بنت أسامة الوزنة. الدكتور محمد بن عيد العتيبي. الدكتور ناصر بن ضيف الله العتيبي. شكرا لكم سعادة رئيس الجامعة لرعاية هذا المؤتمر، وبهذا نكون قد وصلنا إلى ختام حفل الافتتاح، لننتقل بعد ذلك إلى الجلسات العلمية للمؤتمر. ننتقل الآن إلى الجلسات العلمية وافتتاحية الجلسة الأولى، والتي تتناول الاتجاهات الحديثة في التشخيص المبكر للسكتة الدماغية، وأيضا تقييم عوامل الخطورة وآليات اكتشاف السكتة، وأيضا استراتيجيات الحد من مضاعفات وتحسين النتائج العلاجية. وتتناول أيضا الجلسة الأولى الصرع ما بعد السكتة الدماغية. يدير هذه الجلسة الدكتور عبد الرحمن بن عبيد الحربي، يتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. ندعو الزملاء للجلسة العلمية الأولى. الزميل الدكتور سعيد بن صالح الزهراني، واستشاري في طب المخ والأعصاب والسكتة الدماغية، وقائد برنامج طب الأعصاب الافتراضي في مستشفى صحة الافتراضي، ومدير برنامج زمالة السكتة الدماغية في مدينة الملك فهد الطبية، فليتفضل مشكورا. كما ندعو الزميل الدكتور محمود عبد الله الشنقيطي، هو طبيب استشاري في طب المخ والأعصاب والجلطات الدماغية في مدينة الملك فهد الطبية. كما ندعو الزميلة الدكتورة حنان عبد الرحمن الحازمي، طبيب استشاري في جلطات الدماغ وقسطرة الأعصاب التداخلية في مدينة الملك فهد الطبية. كما ندعو الزميلة الدكتورة ابتهال أسامة الوزنة، طبيب استشاري في طب المخ والأعصاب للكبار ورئيس قسم الصرع وتخطيط الدماغ الكهربائي في مستشفى صحة الافتراضية. تتكلم هنا ولا هنا؟ الآن مع الدكتور سعيد صالح الزهراني، بعنوان الاتجاهات الحديثة في التشخيص المبكر للسكتة الدماغية. It's a recent trends in early stroke diagnosis. Welcome دكتور سعيد.
السلام عليكم. صباحكم الله بالخير جميعا. أولا أود أن أشكركم على الاستضافة في المؤتمر الثاني للسكتة الدماغية بعد النجاح المبهر للمؤتمر الأول والحضور المميز، أيضا الحضور المميز اليوم في أولى جلسات المؤتمر. Today I'm going to talk about the recent trends in early diagnosis of stroke. As you know, stroke is اشتغل شكله. Stroke is a major contributor to adult disability, so it's the second cause of mortality, and it is the leading cause of mortality worldwide. 87% of the second is almost 30% of adult disability is caused by stroke. Unfortunately, since 2016 since 1990 to 2016, there is no. How can I just the next slide, please? Yeah. So there is an increase in stroke incidence by almost 9%. And the lifetime risk of stroke is 25%, which if we translated this into just a word, is 1 in 4 people, they are going to develop stroke during their lifetime, which is a frightening figures. But the stroke is a preventable disease as well as is a treatable disease. In Saudi Arabia, we have around 25,000 stroke cases per year, and we have almost 25% mortality rate. And the latest reported thrombolysis rate was 3.6%. This was in 2019. We are glad that this figures is improving now as we go and speaking. There are few challenges to implement stroke treatment and stroke diagnosis. One thing, if you look at the geographic map of Saudi Arabia, it's almost like occupying more than 11 European countries. So there is a very wide geographic area to cover. There's things about public awareness, and I am glad that I saw one poster outside that it showed that public awareness is improving with time, and but there is still no awareness of acute therapy with thrombolysis or with TBA. The narrow therapeutic window, so we have only 4.5 hours. Sometimes it could be extended to 9 hours or for 24 hours for thrombectomy, but that therapeutic window limit transferring patients to tertiary center to receive treatment and to do the intervention. And there are complex diagnostic and therapeutic decisions. So there are multiple contraindications to receive TBA, there are indications, there is an extended time window, and you have to look at the CT scan, diagnose early, roll out hemorrhage. So these are complex decision making you need to do earlier on. And the time is brain. So each minute passed, 2 million neurons died. This is pictures that we always emphasize that a minute is very important. So with each minute, 2 million neurons died, 14 billion of synapses it lost. And per stroke, if it is not treated, the brain ages 36 years. So it's important to have the time. And the time is not a binary entity. So it is not to treat within 4.5 hours or you don't treat. So it is a continuous and biological meaningful. And the time is steepest at the beginning. So although we say 2 million neurons died per minute, but more neurons died earlier in the time window. So whatever we do in the earlier time is better, and we would have very good interventions earlier on. So that's why when we start, or when the stroke system of care is designed, we don't wait for the patients to arrive to the hospitals. We start to implement intervention in pre-hospital pathway with multiple pre-hospital scales, multiple pre-hospital triage, diagnosing patients, moving patients to comprehensive stroke center, bypassing primary stroke centers in certain areas. Those are several evidence that show that we have to intervene even before the patient arrives to the hospital, diagnosing and triaging the patient. This was implemented in Saudi, alhamdulillah. Currently, we have more than 75 hospitals implement pre-hospital stroke scale. So we know about the patients before arrive to the hospitals. There is a screening method that's done for the patients using a fast ED score. And if he scores more than 5, the patients will be directed to a comprehensive stroke center, bypassing the stroke system. This is to facilitate arrival, giving the treatment earlier before. And the prerequisite to activate the pre-hospital stroke scale is to take the patients directly from the ambulance stretcher to the CT scan, to do the CT fast, to be able to make the decisions. This is one entity. The other entity is the mobile stroke unit, and the diagnosis of a stroke case in the emergency hospital, in the ambulance. So there are studies that show diagnosing patient using telestroke, taking history, examining the patient in the ambulance before arrival. It decreases the door-to-needle time by almost 30 minutes. Mobile stroke unit, which is implemented in Riyadh with our colleague in King Faisal Specialist Hospital, last year was used in Al-Hajj season. The ambulance is designed and equipped with the CT machine inside the ambulance. So this ambulance is dispatched to the patient's home and giving the treatment in the patient's home with thrombolysis, and then transferring the patients. It helps in reducing the door-to-needle time. Best MSU trial shows that this intervention improved the functional outcome because it decreased the time of thrombolysis, as well as Melbourne cost-effectiveness study shows that it is even, although there is an upfront cost, on the long term it's a cost-effective intervention. So it decreased the hospitalization stay by almost to 4 to 6 days, more than the conventional pre-hospital stroke activation. The ICU stay is lowered, rehabilitation need is shorter, disability at 1 year is lower, and the patient productivity loss is shortened with the implementation of mobile stroke unit. The mortality rate at 1 year is even less with this intervention because you will administer the patient earlier. The American Heart Association and American Stroke Guideline was published just last week, and the latest recommendation, the mobile stroke unit implementation, is Class 1 Level A evidence. So it's now a very strong recommendation to utilize a mobile stroke unit in earlier diagnosis. So what about if a patient arrives to the hospital? Unfortunately, our recent data showed that only 20% of stroke patients call 911. 80% they came walking. And worldwide, we have a shortage in neurologists. This is last published in 2019 in Neurology Green Journal. And in Stroke Journal as well, there is a growing shortage of vascular neurologists all over the world. So to overcome this and to treat patients in distant site, telestroke method is implemented. Telestroke is the same as you are evaluating the patient as bedside. You are evaluating the patient through a telestroke by utilizing an audio and video system. It showed that it decreased the time to diagnosis, decreased the time door to needle time. You could have a better outcome because you will treat more patients with thrombolysis, and you will increase the IV TBA rates, and even for patient satisfactions, for even physician in emergency room satisfaction, there will be satisfied. We implement this in Saha Virtual Hospital. We have a telestroke command center with specialized stroke neurologists, specialized stroke trained nurses that we saw patients and examine the patients. This happens through an integration with different HIS system with Saha Virtual Hospital and different PACS system to see the images with for the stroke neurologist, as well utilizing the mobile stroke cart to see patients, examine the patients, take more history, and even we utilize this for monitoring even after administering the IV TBA. Sometimes the nurses is monitoring the nurses in the spoke hospitals to how to mix the TBA and how to give the TBA in real time. This is our latest dashboard. This is we have a continuous KPI monitoring in Saha Virtual Hospital. We treated until now more than 11,000 stroke patients with 7,200 stroke patients. Our thrombolysis rate, as I told you, the thrombolysis rate was 3.9%. Current thrombolysis rate is 28%, with the thrombectomy time, transfer thrombectomy is 11%. This shows the improved access by more utilization of TBA, the door-to-needle time reduced by 25%, and we are currently connected with 55 hospitals. There are as well some of the important intervention that's made is by utilizing an AI software, or by utilizing Rapid AI, Viz AI, or Brainomics AI software to analyze and interpret imaging. There is an image interpretation that shows us an aspect score and shows us an ECTA score and shows a CT perfusion. This is in clinical practice since long time. It's nothing new, but we start utilizing it and using it in our daily clinical practice, which help us to increase, open the window for intervention for thrombectomy and increase the window for intervention for thrombolysis as well. Hopefully we would reach a virtual infrastructure that will connect all parties together, mobile stroke unit, ambulances, pre-hospital ambulances, and with comprehensive stroke center and neurointerventionist and radiologist to do all the work and streamline the process of interventions in ambulance, in primary hospital and comprehensive hospital. With this I end. This is from Al-Baha. I invite you to visit. This is last before 4 months, my pictures. Thank you very much.
Thank you, Dr. Saeed. We'll keep the questions at the end of the session. I'm sure there is a lot of questions in this topic. Now with Dr. Mahmoud Al-Shankiti. He will talk about the risk factor assessment and the stroke detection mechanism. Welcome, Dr. Mahmoud.
السلام عليكم. الله يعطيكم العافية. أول شيء أتشرف بوجودي معكم في هذا المؤتمر. So I'll talk today about comprehensive assessment of stroke risk factors. Stroke risk factors is a large topic. I'll try my best to give you how to comprehensively assess stroke risk with recent evidence. So I have no disclosures. So my objectives today is we'll go through traditional risk factors with recent evidence, and also I'll shine a light on the unrecognized uncommon risk factors with the emerging stroke risk factors in the recent years. So we'll start with the traditional risk factor. As we know, diet, obesity, sedentary lifestyle, hypertension, diabetes, smoking, these are well-known traditional risk factors. The new thing is worldwide right now, in the recent guidelines, they reframed the way to look for vascular risk factors. Instead of looking and targeting single risk factors like blood glucose or blood pressure, it's a comprehensive way. In a way, we integrate all the lifestyle habits in forms of sleep, diet, physical exercise, with the comorbidities as well. This is now the cornerstone. This is a life essential aid introduced by the American Heart Association in the recent guidelines. So we'll start with the diet. So as we know, for intermediate and high cardiovascular risk, there is good evidence for Mediterranean-style diet. Sodium salt substitution is good, mainly for those who are older than 60 years. What is not recommended is omega-3 fatty acid in terms of stroke, and folic acid B complex, there is no sufficient data. Antioxidant multivitamins, no stroke benefit until now. For the physical activity, we know that activity more than 150 minutes per week or more than 75 intense activity can reduce stroke. For the weight, based on the BMI defined obesity, any increase can cause 10% higher stroke risk, especially if it's more than 5 kilograms per meter square. We know for a fact that bariatric surgery may be considered in patients with obesity and can reduce stroke. Sleep is important. We know that obstructive sleep apnea can cause stroke, especially if the apnea-hypopnea index more than 5. It can increase stroke risk by 10 to 20%. Observational data suggests that CPAP might help and can reduce stroke. Smoking is bad in every system. For stroke specifically, it can affect all kinds of stroke, can increase the relative risk of ischemic stroke 2.1, ICH 1.7, subarachnoid hemorrhage 3.5. Even second-hand smoking can increase the stroke risk, and also the smokeless tobacco. What about the medications for smoking? Any evidence for stroke? So we know that medications can help quitting. Quitting can reduce stroke risk, but there is no direct evidence that these medications specifically can reduce stroke risk. When does stroke risk normalize after quitting? There are many studies, but in many cohort approach, the never smoker levels reach around 10 years, so 5 to 15 years, depending on prior smoking intensity. Now I'll talk about diabetes. Diabetes is a global burden. More than 370 million people affected worldwide, expected to reach around 550 by the year 2030. Type 2 diabetes is a major cardiovascular risk. It's an independent risk factor for ischemic stroke with twofold increase in stroke risk. In our beloved country, Saudi, we have 23 to 25% prevalence of diabetes, which is a scary number. The more concerning part is the trajectory that by year 2050, around 9.5 million people will be affected by diabetes. How can diabetes cause stroke? This is a quick graph just highlighting the mechanisms. Most common mechanism is microangiopathy, can cause small vessel disease due to endothelial dysfunction. The recommended target for diabetes for hemoglobin A1C is less than 7. There is no strong RCT that can confirm that decreasing A1C less than 7 prevents stroke. However, there is good evidence it can reduce microvascular complications in general. What about after stroke? So after stroke, acute treatment, does intensive glucose control after stroke prevent more stroke? This is a study, the SHINE trial published in 2019, investigated intensive IV insulin versus control and showed actually no improvement in functional outcome. And the trial was stopped early for futility due to higher and severe hypoglycemia. What about diabetes medication? Recently now we have good evidence for the recent diabetes medication. The traditional medication, we don't have clear stroke risk, but with the new medications, we have good evidence. For this SGLT2 inhibitor, we have meta-analysis in 2021, actually showed no reduction in stroke, in overall stroke risk, but there was a trend toward lowering hemorrhagic stroke. For the TZDs, this is the IRIS trial published in 2016, showed reduced recurrent stroke or MI. And for the GLP-1, this is the strongest evidence that we have for diabetes in reduction of stroke. The GLP-1, we know Ozempic. This is the evidence based on the SUSTAIN-6 trial published in New England Journal of Medicine 2016, showed reduced non-fatal stroke by around 2%. In the REWIND trial, they studied the other GLP-1, dulaglutide, and showed reduced non-fatal stroke as well. We have new evidence for the GLP-1. We have 2 trials published in 2025 for the oral GLP-1. The SOUL trial published and showed reduce in major adverse cardiovascular events. However, no significant reduction in non-fatal stroke. The LAMB trial studied patients who acutely admitted as stroke, and they administered for them liraglutide, is a form of GLP-1, and showed reduced recurrent stroke within 90 days. This is a summary of diabetes medication with their stroke risk. As I said, for the traditional medications, sulfonylurea, insulin, metformin, they are important in forms of controlling glycemic control, but there is no good evidence that they reduce stroke risk. Now I'll talk about hypertension. Also is a global burden, around 1.3 billion affected worldwide, only 20% controlled. It attributes to 50% risk of ischemic stroke and 60% risk of hemorrhagic stroke. In Saudi Arabia, around 30% of adults more than 30 years have hypertension. This is a scary number. What's more concerning is our average is higher than the global average. And only half of those who has hypertension diagnosed, and only 20% they have well-controlled blood pressure. Also, blood pressure, hypertension can affect small vessel disease by lipohyalinosis and endothelial dysfunction. So the evidence of antihypertensive medication preventing stroke started in the early 1970s by the Veteran Administration Cooperative Studies. They administrated that antihypertensive medication prevents stroke and its related complications. Then in 91, the SHIP trial, this was the first RCT that showed blood pressure treatment can't prevent stroke, and they focused on the systolic blood pressure, and they showed that decreasing blood pressure less than 160 can prevent 36% of stroke. After that, the HOT trial in 1998 showed us that lowering diastolic blood pressure less than 90 is safe. Then the ALL-HOT trial showed us that thiazide-type diuretics are superior as first-line hypertension and can lower stroke with the lowest cost. These all are for primary prevention, so for patients without any history of stroke. The last evidence for primary prevention, the SPRINT trial in 2015, they said, let's drop blood pressure even more. So they studied intensive blood pressure lowering systolic less than 120 versus 140. It showed reduced cardiovascular events, but however, at the cost of more hypotension, electrolyte abnormalities, and kidney-related events. So for secondary prevention, It's complicated, as you know, for targeting blood pressure after stroke. So we know in the acute stage, if the patient is receiving IV thrombolytic, the target change before and after less than 185, before and after less than 180. For endovascular therapy, the recommended target is less than 180 over 105. The new evidence with the recent guidelines that was published last week that after successful EVT, dropping systolic blood pressure less than 140 is harmful. So it should be between 140 and 180. Couple of trials that are important in secondary prevention for hypertensive patients. The PROGRESS trial, patient with prior stroke and TIA, they studied perindopril versus placebo and showed reduced recurrent risk by around 28%. The SPS3 trial, which is a large study that studied many things. One of the things was lowering systolic blood pressure less than 130 in patients with lacunar stroke. There was no statistical significant reduction. However, there was trend toward fewer strokes. For the lipids, dyslipidemia affects more than 40% of people worldwide. It's a modifiable risk for atherosclerotic cardiovascular disease. The mechanism in which dyslipidemia can cause stroke is by atherosclerosis, so either large artery atherosclerosis, ICAD, or artery-to-artery embolism. We know that higher LDL means higher stroke, lower LDL, lower stroke. So for the primary prevention of lipid management, started in year 2002 by the Heart Protection Study. They investigated patients with higher risk for cardiovascular disease and found that simvastatin 40 milligram can reduce stroke significantly with number needed to treat 19. This is regardless of the baseline LDL. Then the Jupiter study in New England Journal of Medicine showed also patients with high LDL and high C-reactive protein, when they give rosuvastatin, stroke can be reduced by around 50%. Then the HOPE-3 trial investigated patients with intermediate risk of cardiovascular disease and showed that rosuvastatin 10 milligram can decrease stroke as well, with number need to treat around 200. For secondary prevention, the most famous trial for lipid management is the SPARKLE trial, published in New England Journal of Medicine in 2006, which studied high-dose statin, atorvastatin 80 milligram versus placebo, and showed reduced stroke risk by around 60%. In the secondary analysis, there was some concern about increased hemorrhagic risk, but in future studies, it was not present. What about other medication other than statin? We have evidence for the Repatha or evolocumab, introduced after the Fourier trial in 2017, which showed major reduction in cardiovascular event and specifically ischemic stroke with no increase in hemorrhage. We also have evidence for isocabant ethyl 4 gram, especially in patients with high triglyceride. And this study, what's interesting, they studied patients who are already on statin. So in statin-treated patients with high triglyceride, adding isocabant ethyl can prevent or can reduce stroke by 25%. What about targeting the lipid management, targeting LDL? So we have a Treat to Target trial in 2020. This trial showed us that intensive LDL lowering is helpful. So they studied LDL less than 70 compared to less than 90 and showed that intensive LDL lowering can prevent cardiovascular events by around 22%. This is a large meta-analysis done in 2020, more than 20 RCTs included, and it confirms that more intensive lowering of LDL is helpful. So those were the traditional risk factors. Now for the uncommon and the underdiagnosed risk factors, migraine is an important risk factor with around 2-fold increase, silent cerebral small vessel disease, also autoimmune inflammatory disease such as SLE, antiphospholipid antibody syndrome, some specific conditions for female, like hypertensive disorders of pregnancy, premature menopause as well. Some genetic disease important in our country, sickle cell disease, has high prevalence and carries high risk of stroke, also CADASIL. One other underdiagnosed and recently people are trying to do more studies in it is lipoprotein A. So lipoprotein A was discovered in 1963. By the year of 2009, American Heart Association established it as an independent risk factor and can cause major atherosclerotic cardiovascular disease. So who should be tested for lipoprotein A? For all adults, it's only enough once in a lifetime, but specifically for patients with premature atherosclerotic cardiovascular disease, patients with recurrent stroke despite good LDL level, patients with familial hypercholesterolemia, first degree relative with lipoprotein A. It's measured through a blood test with immunoassay-based methods. If targets more than 30, this carries a risk for stroke. There is it's not related to diet, physical exercise, or obesity. And the way to treat it is, for now, aggressive lower LDL by statin, ezetimibe, the newer medication as well. What about specific medications for lipoprotein A? Many phase 2 and phase 1 trials were published. There is ongoing, the promising medication is belacarsen for the lipoprotein A. It's an antisense gluconeolyside targeting the messenger RNA in the liver. Actually, the trial is now, we are expecting publication of the trial, and it showed good promises. The other thing I want to talk about, what's emergent now, is microplastic and nanoplastic. We are exposed to plastics every day. So plastics, after released, they don't go away. So they confirm and break to microplastic and nanoplastic. These plastics can enter our body through ingestion, through drinking, from coffees, from bottled water. And this was non-concerning before, but what's concerning is the risk of cardiovascular events. This was a trial that was published in New England Journal of Medicine in 2024. They studied patients with carotid stenosis, with carotid plaque, and they said, let's study these plaques. Let's see if there is any plastics, microplastic or nanoplastic. And they found 58% of carotid plaques contains microplastic and nanoplastic, which is a scary number. They found mainly polyethylene and some polyvinyl chloride. These are the particles that they found by laser transmission electron microscope and scanning electron microscope as well. The primary outcome of the study is that these patients with microplastic and nanoplastic can it increase the cardiovascular risk. And yes, the presence of microplastic associated with markedly higher cardiovascular risk. This is a scary number, and it can change the way we look at materials like everyday activities methods, like drinking from cups, bottled water. The other emerging risk factor is a climate change. So for climate change, this is a study that showed that with extreme cold days and extreme hot days, the stroke can happen more with the extreme cold days, especially hemorrhagic stroke. Other worth mentioning emergent risk factors: metabolic dysfunction, fatty liver, infection, especially post-COVID-19. There were a lot of talks about higher stroke risk with vaccine, with the virus itself. Cannabis use can increase stroke risk, and also air pollution with particulate matter of less than 2.5 millimeter. So take-home message, I know it's a large topic, but take-home message: stroke is largely preventable. if we implement comprehensive healthy lifestyle, we can target the stroke from the early stages. Lifestyle is a treatment, sleep matters, smoking cessation actually works. Hidden risks are common like migraine, silent small vessel disease, sickle cell disease, CADASIL. Measure what change management. If you are not sure about what's the etiology of stroke, you can always measure the rare things. Emergent risk factors are real, infections, cannabis use, microplastic, all can increase thrombotic risk. Thank you.
Thank you, Dr. Mahmoud. It's very interesting about when you talk about microplastic and plastic, which is in our life every day, and the risk related to the stroke, and maybe we have a lot of questions related to this topic. Now with Dr. Hanan Al-Hazmi. She is a consultant stroke neurologist with intervention. She will talk about strategies to reduce complication and improve the clinical outcome. Welcome, Dr.
Assalamu alaikum. Thank you to the organizing committee for the invitation. I'm honored to be here with you. So stroke is a major public health problem. It is one of the leading cause of death and disability worldwide. Around 12 to 15 million people have a stroke every year. And in the United States, someone has stroke every 14 seconds. Also, in Saudi Arabia, stroke is the second leading cause of death and disability, with an average incidence of 19 to 57 cases per 100,000 people, with reported mortality rate of 27%. Over the past years, the number of stroke cases has increased and expected to be rising due to mainly aging of the population and the cardiovascular risk factor. However, even though we see more stroke, the stroke-related disability decreased since 2010 due to the better access to stroke reperfusion and stroke care. Reperfusion therapy has fundamentally transformed the management of acute ischemic stroke. Many patients, if treated on time, can recover and regain their functional independence. By restoring cerebral blood flow before irreversible infarction occurs, intravenous thrombolysis and endovascular thrombectomy has changed ischemic stroke from disabling condition to one that can be treated. This is a pool analysis from the NINDES trial. As we can see, the benefit of thrombolysis decreases with time, with the greatest benefit if it is administered within the first 90 minutes. So the stroke care is described as a chain of survival where every step matters. The first step is early recognition of stroke symptoms by patients and family, then activation AMS as soon as possible. The third step about pre-hospital activation and assessing the patient and transfer the patient to the right hospital while alerting stroke team. Then activation code stroke in the ED triage, rapid evaluation and imaging in the emergency, early reperfusion therapy, and rapid admission to stroke unit. So the challenge in acute stroke management is reducing onset to needle times by better public education of stroke symptoms, better recognition of stroke symptoms by dispatchers, reducing on-scene time, taking patient to the right hospital, and pre-alerting stroke team, measuring efficiency by door-to-needle time. So reducing time for acute ischemic treatment begins before the patients arrive at the hospital. Pre-hospital activation is proven to improve the clinical outcome in acute ischemic stroke by shortening onset to door and door-to-needle times for intravenous thrombolysis and improve the access to endovascular thrombectomy for the selected patient. Multiple studies have shown that AMS pre-notification is associated with faster imaging, earlier treatment, and higher rate of reperfusion therapy, translating into better functional outcomes. For pre-hospital setting, stroke scale help MS to detect stroke and make a decision. So we have two types of stroke score. The first score is to detect stroke, like fast stroke score and CBSS, which consider facial drop, arm drift, and speech difficulty. The second type of score used is fast ED and DRESS plus. This is to detect large vessel occlusion to transfer the patient directly to thrombectomy capable center. So this is our experience at KFMC. So we initiated the pre-hospital notification pathway with the Saudi Red Crescent in 2022. So when we compare patients who came with the pre-hospital notification with this, when notification happened in the emergency department, we saw that pre-hospital notification reduced door-to-CT time from 24 minutes to 12, and door-to-needle time from 47 to 22 minutes. Mobile stroke unit is an advanced form of pre-hospital notification. It is a specialized ambulance equipped with CT scan, point-of-care laboratory testing, and telestroke, and thrombolytic therapy, enabling on-scene stroke diagnosis and treatment. That help to ultra-early imaging to exclude hemorrhage, giving intravenous thrombolysis, and finding the right patient with large vessel occlusion to transfer him to a thrombectomy capable center. In the emergency department, from the AHA guidelines, the door to emergency doctors will be within 10 minutes, imaging within 25 minutes, and the door to needle time within 60 minutes. As we discussed previously, IV thrombolysis, the benefit of it is strongly time dependent, and the greatest functional benefit if it is administered within the first 90 minutes. And that reflects in number need to treat less than 5. So IV thrombolysis improves the outcome but has limited recanalization rate in large vessel occlusion. Those patients had severe stroke and bad prognosis. So endovascular thrombectomy is the gold standard reperfusion therapy. The door-to-groin puncture time is 90 minutes, and we acquired this by early CTA imaging, immediate neurointerventional and anesthesia team activation, and direct transfer from CT to angio suite. Shorter door-to-groin times are consistently associated with higher reperfusion rate and better functional outcome. Admission to stroke unit is associated with reduced mortality, lower dependency, and improved functional outcome. It provides specialized multidisciplinary management and enables early mobilization, swallowing assessment, and rehabilitation planning. Continuous neurological monitoring allows early detection of deterioration and secondary complication. Standardized protocol reduce preventable complications like aspiration, pneumonia, infection, hyperglycemia, and early multidisciplinary rehabilitation improve functional recovery. Preventing post-stroke complication by early dysphagia screening, physiological optimization of blood pressure, glucose, and temperature, early mobilization and DVT prevention, infection prevention, skin care and nutritional support, early secondary prevention, and rehabilitation planning. So the strong system, we need to have standardized stroke pathway across pre-hospital, emergency department, angiography, and stroke unit care. We need continuous monitoring of time metric, door-to-needle, door-to-groin, and complication rates, multidisciplinary training and feedback loops, and integrated stroke system. Thank you.
Thank you, Dr. Hanan. It's a very important endovascular treatment for stroke patients plus the therapy. Now, Dr. Tihal Al-Wazna, she is a consultant adult neurologist and head of epilepsy and EEG department in Virtual Health Hospital أو مستشفى الصحة الافتراضي. She will talk about post-stroke epilepsy اللي هو الصرع ما بعد السكتة الدماغية. تفضلي دكتور.
أهلا، شكرا للدعوة. It's my honor to be here today and thank you so much for the invitation. Today I'll talk about post-stroke epilepsy. My objectives are recognize post-stroke seizures and distinguish early versus late onset, identify high-risk stroke patient for seizure development, identify seizure through clinical approach, initiating anti-seizure medication, and when to refer to neurology for specialized care. This topic is really important because stroke are the most common etiology of epilepsy in patients 65 years and older. It's associated with longer hospital stay and increased mortality, especially with early onset. Seizures significantly impair rehabilitation and functional outcome in post-stroke patients, and it can be frequently missed or misdiagnosed as delirium or post-stroke progression. So what is seizure? بطلعكم شوي من الستروك. It's a transient occurrence of signs and symptoms. It is usually due to an abnormal, excessive, or synchronous neuronal activity in the brain. Post-stroke seizures is a seizure occurring after a cerebrovascular event, and post-stroke epilepsy defined by the International League Against Epilepsy to be unprovoked seizures occurring more than 7 days after stroke and have high risk for recurrent seizure. So it's important to distinguish between single event and a chronic condition of epilepsy. The incidence of seizures occurring from 5 to 15% in all stroke cases, making it a common complication. Risk is higher with the high-risk group like hemorrhagic stroke and cortical involvement. And stroke is account for half of all new onset epilepsy cases in the elderly patient. Timing is really essential. It guides prognosis and treatment decisions. For the early onset seizures, it starts at 7 days or before post-stroke. It's often single seizure event and have lower recurrence risk and not always necessitating long-term epilepsy treatment. On the other hand, the late onset seizure happens after 7 days post-stroke, and the recurrence without intervention usually happen, and long-term anti-seizure medication with specialist follow-up is recommended. To understand this figure of pathophysiology, differentiate the early seizures and late seizures. Initially, stroke cause blood-brain barrier disruption, cellular hypoxia, electrolyte imbalance, and ion channels dysfunction, and that will lead to early seizures. However, subsequently, the epileptogenesis will be acquired after secondary changes, like gliotic scarring, angiogenesis, neurodegeneration, neurogenesis, apoptosis, and also hemosiderin deposit that will cause epileptogenesis. So this late seizures will, epileptogenesis will cause recurrent and post-stroke epilepsy. On the other hand, the early seizures is only a provoked seizure and it might not reoccur again. Risk factors are important to look for. The cortical involvement is the highest risk for post-stroke epilepsy, hemorrhage stroke, even ischemic stroke with hemorrhagic transformation, larger infarct with higher NIHSS score, early seizures occurrence, which can predict late seizures, and younger age due to severity and type of stroke. This figure shows that type of stroke is important risk for post-stroke seizures, like we mentioned before, the cortical and hemorrhagic stroke, as it appears here in the CT brain. So what are the clinical presentations for post-stroke seizures? Any seizure can appear. Generalized tonic-clonic seizures, focal seizures, depend on sometimes it's related to the site of the stroke. Also aphasic seizure, behavioral arrest, and even status epilepticus. Non-convulsive seizures are commonly missed. It's important for any patient with unexplained confusion, reduced consciousness, fluctuating neurological deficit that are high prevalence in ICU patient and elderly to do an urgent EEG. Here just to show that seizures can come as a focal onset or generalized. The focal originates in one area or hemisphere of the brain, rather than the generalized occur in both brain hemispheres at onset. Seizure mimics are also very important to look after, to be ruled out. We have like cardiovascular causes like syncope, postural orthostatic tachycardia syndrome, migraine with aura or hemiplegic migraine, sleep disorder like narcolepsy with cataplexy, movement disorder, periodic leg movement in sleep, panic attacks, and psychogenic non-epileptic spells. Causes for provoked seizures include alcohol withdrawal, withdrawal from chronic drug abuse, acute intoxication of drugs, and importantly, metabolic disorders that can appear frequently with the patient with stroke, like hypocalcemia, hypoglycemia, hypo and hypernatremia, hypomagnesemia and uremia, hypoxia, hyperthyroidism, dialysis disequilibrium syndrome with renal dialysis, porphyria, and pyridoxine deficiency. Assessment and diagnosis of post-stroke seizures, like any other seizures, we have to go through detailed clinical history, age, gender, and handedness, past medical history, including medications, social history, and epilepsy risk factors. It's important to look for any history of head trauma with loss of consciousness, CNS infection, family history of epilepsy, perinatal distress, and febrile seizure at childhood. Understanding semiology is very crucial in neurology clinics, and especially epilepsy clinic. We have to go through all the pre-ictal, ictal, and post-ictal symptoms in very detail. Subjective information and collateral history are crucial because diagnosis might be difficult in some cases, like non-convulsive seizures, unusual seizure semiology, and seizure related to sensory symptoms. This is just to show you how semiology can be very variable and long symptoms can appear to the patient. This is just the frontal lobe. Here is the temporal lobe and the other lobes. Then we'll go through the clinical examination. Vitals is important to check for pulse, looking for arrhythmia and fever, general examination, signs of infection and intoxications, cardiac exam, neurological exam, including level of consciousness, pupils, neck rigidity, or any weakness, of course, evidence of traumatic injury. Todd's paralysis is a transient post-seizure weakness. It occurs in the focal area affected by the seizure activity and usually lasts for minutes to hours. It closely mimics a new stroke and leading to diagnostic confusion. So if patient came with seizure and had a weakness, make sure it's not thought paralysis to avoid giving thrombolytic and other medications. EEG is one of the most important tools in diagnosing epilepsy. Clinical indications include unexplained altered mental status, suspected non-convulsive seizures, monitoring ICU patients, and status epilepticus management. EEG finding can be simple and diagnose epilepsy, but sometimes it's just showing finding of high-risk patient to develop post-stroke seizure, like periodic lateralized epileptiform discharges. And sometimes it can be a normal EEG, but that should not exclude epileptogenicity. Brain CT is a primary tool to rule out hemorrhage or acute bleeding. Rapid assessment of mass effect or midline shift. However, MRI, of course, is a superior for identifying cortical lesions, detect hemosiderin deposits, and helps localize the potential seizure focus. Treatment. So, do we give prophylaxis? This question is old, and the answer is still the same. Primary anti-seizure medication prophylaxis is still not recommended. However, there is some exceptions, like acute symptomatic or early seizures, short-term anti-seizure treatment for like 1 to 4 weeks, depend on the case, can be given, especially with the high-risk cases like cortical strokes and hemorrhage. Neurosurgical cases use post-operative prophylaxis per surgical protocol also. Five important management principles need to be considered in managing post-stroke epilepsy. We have to treat first the acute seizure, identify early versus late, assess recurrence risk, decide on anti-seizure medication initiation, and then refer when appropriate. So, acute seizure medication or treatment require first immediate intervention, make sure the patient is stabilized and safe, protecting his airway, breathing, and circulation. We can start first-line management for seizure, the benzodiazepine, if the patient have prolonged seizure or recurrent seizure, and also IV fluids. We have to correct reversible causes or factors and look for them closely, like electrolyte imbalance, hypoglycemia, hypoxia, and metabolic acidosis. So when do we have to start anti-seizure medication? It should be started with clinical seizures are observed in post-stroke patients. Also with electrographic seizures and patients who have clinical seizures time-locked with EEG finding like periodic lateralized epileptiform discharges. Which anti-seizure we can choose? There's a first generation and second generation anti-seizure medications. First generations include the carbamazepine, phenytoin, and valproic acid. They usually have significant drug-drug interaction, especially with stroke patients who's on multiple medications. We rather like to go with second generations like levetiracetam or Keppra. Lamotrigine had superior tolerability. There are some differential diagnoses in post-stroke seizures. New symptoms appear to the patient post-stroke, like post-stroke alteration in the autonomic system, like orthostatic hypotension, arrhythmia, and syncope. Need to keep in mind that it might confuse with seizures. And also post-stroke movement disorder. It might affect 1 to 4% of all stroke patients, so dystonia, chorea, myoclonus should be differentiated from seizures. So let's do some exercise. A 70-year-old man with large cortical MCA infarct had seizure on day 2 post-stroke. What is the most likely diagnosis? Any volunteer?
Keep it for the medical college medicine student.
What is the immediate and long-term management?
Yeah, third or fourth year medicine.
So first, is this early onset or late onset seizure? Post-stroke seizure?
You can answer it.
Excellent. So this is a likely provoked seizure. It's an early onset seizure, happened prior to 7 days post-stroke. And what is the immediate and long-term management? These, we have to go through acute seizure management and correct the reversible causes. Case 2, a 65-year-old woman, ICH 3 months ago, and first seizure happened today. What is the most likely diagnosis?
Hello, what is our student? 4th, 5th year?
So it's our topic, post-stroke epilepsy, because the seizure appeared more than 7 days, and we have to initiate anti-seizure medication, do a proper and selective workup like EEG, brain MRI, and CT. Take-home message, stroke is a major cause for seizures in adults. Timing defines prognosis, early versus late post-stroke seizures. Do not over-treat early seizures with long-term anti-seizure medications. Late seizure equal epilepsy in most cases. Levetiracetam is generally the first-line choice, and when in doubt, utilize EEG and neurology consultation. Clinical precisions improve patient recovery and safety. Thank you so much.
We can open like a short time for questions for our expertise in stroke and epilepsy. Anyone have any questions while we are preparing the scientific paper? Yes, تفضل دكتور.
كيلو مجمع. Is confront. How far you think we should go? Meanwhile, our Thank you, Dr. Saeed.
Thank you for your questions. I think you touched a very important element. As I mentioned, one of the barriers is the public awareness. There are certain things that we could do and certain things that we are in our capacity. I think your questions was when we start our national telestroke program and the stroke urgent care model, that we are at that time we are not prepared to receive patients. So if we educate patients and then our hospital are not equipped, for example, especially in peripheral hospital with telestroke or with thrombolysis, and there is no proper stroke system of care, then what is the point of doing the public awareness? While now I think most of the cities around the kingdoms, they have at least one center that treats stroke patients. And with the integrations with Red Crescent, they already recognize the centers where the treatment is available, and they talk the patients to the centers where the treatment is available. There are still, as I mentioned in my presentation, unfortunately 80% of populations, they came walking, and 20% only they call the ambulance. So this is another challenge that people, they need to call the ambulance to be better triage and better taking the patients to the appropriate services where the acute stroke treatment can be provided. For the part of public awareness, I think we tried our best. I was glad to see one of the posters outside that it showed that 92% of public, they are aware of stroke symptoms, but only 20% they are aware that there is an acute treatment with thrombolysis, which we need to raise that percentage even higher. We are doing a stroke awareness day yearly, and last year I was happy to hear that the stroke symptoms and stroke signs will be in the teaching curriculum in schools, in elementary and secondary school as well. These things could enhance our public awareness. We are still way behind, unfortunately, in terms of utilizing the new media as well. We designed one short video clip. It's in our Stroke Society webpage and in X, Twitter, that shows stroke symptoms and the difference between if you treat early and if you treat later. This, I think, what we are doing, and hopefully this will be increased. One thing is those conferences, the medical student that they attend, they goes back to their families, they goes to the doing a campaign in malls and in every occasion, just to teach the stroke signs and symptoms and stroke treatment as well. Thank you.
Thank you, Dr. Saeed. I think, we need more efforts between and collaboration between not only the hospital or what they are doing in Saha, like hospital. It's a huge effort, especially for the periphery hospital. But I think it's still collaboration between universities and other like institute other than the health institute will be very important. Any other questions, or can go for scientific paper? Yes? Yeah. تفضل.
I'm very amazed that doctors, all of you, that explain a very deep knowledge in a very short time. My question from Dr. Saeed Saleh Al-Zahrani, if we can see that the kingdom geographically is very wide, but if we go through the population, is 35 to 40 million. So why the mortality rate is very high? It's 40%. So what mistake we do in our life and what mistake do in our diet? What are the mistakes that we do and what are the precautions?
Yeah, thank you very much. So the mortality rate was reported in 2019. That was 40% with stroke. I think what is still lacking in our system of care is the wide implementation of stroke unit, which will take care of stroke admitted patients. And one of the important items that decrease the mortality, which shows the decrease the mortality significantly, is the stroke unit implementation. We are still lacking in terms of wide implementations around the kingdom of stroke unit. We are doing our best efforts in implementing these strategies to implement the stroke unit admission for all stroke patients. It is one of the targets for health holding company is more than 80% of stroke patients should be admitted directly to a stroke unit, where everything is happening, preventions of complications, which will cause mortality after a stroke. This is a target that we are hopefully nearly we will reach that, and mortality will decrease. The other intervention that we are doing earlier on is again by implementing the fast diagnosis of stroke, earlier diagnosis, earlier treatment as well, which is important. And the most important is that we prevent stroke from happening. So this is another target the هيئة الصحة العامة is working on implementing we call it الصحة في كل السياسات, health in all policies. So there's a wide implementations to decrease to prevent stroke from happening to start with.
One more question. I know it's a hot topic actually, and there is many things about even intervention and epilepsy. تفضل دكتور.
Thank you all for the wonderful and informative talks. But I got questions for Dr. Mahmoud. Is there any early blood markers that can be used to predict stroke before it happens? And the second part, if you don't mind, as stroke is linked with age, do you think it would be good or nice idea to get aspirin for aged people like 60 and above? Thank you.
Thank you for the great question. For the first question, so what you are referring to is primary prevention. So primary prevention, as I said, it changed from targeting single target, single lab, single parameter. The cornerstone now is comprehensive assessment of healthy lifestyle. So healthy lifestyle mean diet, physical exercise, no smoking, good sleep, then the well-known primary prevention of diabetes, lipid management, atherosclerotic disorders, and hypertension. For the second question, as for now, there is no great evidence for giving antiplatelets as a primary prevention for stroke. By that I mean there is no RCTs, no big studies that show us it's common. We always forget that all these medications have side effects. So practically we see it case by case. I mean, sometimes if there is high atherosclerosis burden, comorbidities, sometimes we think that we can give antiplatelet as a primary prevention. But in short answer, most of the cases we don't give antiplatelet as a primary prevention.
They are asking our students about the timing or intervention as your interventionist. Like if it's, they are talking about, you said maybe first 24 hours. Some nowadays they are talking about before either post-TBA or without TBA, anterior circulation or posterior circulation.
I think Dr. Mohammed Adeli will talk about it after noon, but for now, the time for thrombectomy is within the first 6 hours for all patients with large vessel occlusion, and we extend the window up to 24 hours in selected patient after imaging selection. Like when we do perfusion imaging and there is a large penumbra, so in this patient we can extend the window up to 24 hours in anterior and posterior circulation.
Thank you. And Dr. Abtihal, we have one of our colleagues here from Majma'a area, and they are asking about if we have patients either post-stroke, seizure or epileptic, and they call to Sahha Iftiradi Hospital, and how they manage patients with seizure in Majma'a while you are in Riyadh.
Thank you for this question. So you're asking about how Sahha Virtual Hospital helping seizure or stroke patient. طبعا stroke ما شاء الله دكتور سعيد ما قصر. بالنسبة للسيجر we have an epilepsy department with EEG connecting 28 hospitals around the kingdom. We connect with live EEG. We can do as outpatient, inpatient, or even ICU patient. And sometimes we have confirmatory brain death for organ donation. We have connection with Scott. We have epilepsy clinic and neurology clinic. And we can follow up the patient. We can contact the physician who is treating the patient if we see any abnormality in the EEG while doing the report.
Okay.
Did I answer the question?
Thank you. That's mean our patients in Majma'a area, it's like we are, we have a neurologist and through the virtual hospital from Ministry of Health. Thank you very much. And now we'll talk about, we have scientific paper.
Excuse me, just got a question here. Okay. So thanks for the speakers for the nice and beneficial talks. Just got a question for Dr. Mahmoud about the microplastics. So do you see that the microplastic exposure becoming like a modifiable risk factors for the like stroke in the future, like for example the air pollutions or such a things?
So this is the thing. We can't modify our exposure to plastics. We are talking here about microplastics and nanoplastics. Microplastics as less than 5 nanometer, nanoplastic less than 10,000. So plastic, as I said, it doesn't go away. So if we can modify this, we need to stop creating plastic, which we can do. The thing we can modify is how we can expose to it. So if you can imagine you are holding a cup of coffee, water bottle, even your phone cover is all plastics. So this is becoming a trend now, especially in the Western countries, for changing all these consumable things to something organic. And of course, we need more studies to confirm the effect on the cardiovascular system and in our health.
Thank you so much, Doctor. I think it's a very interesting topic, actually, especially the microplastic. Thanks.
Yeah.
Well, my phone, the cover is plastic. That's why I'm worried about. Is there any risk of stroke now? Now we'll talk about, there is a scientific paper from our colleague, his name Dr. Ahmed Zahir Qureshi. He is one of our colleagues from, he's a consultant physical medicine and rehabilitation, Sultan bin Abdulaziz, humanitarian. We'll talk about one scientific paper. Thank you very much.
Rahmatullahi wa barakatuh. Thank you very much for having me here today. Do we have some technical help here? Thank you so much. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. I know we are about to reach the break time. I'm going to do the presentation in a slightly unconventional manner to make it more appealing for the diverse audience we have over here. So we have had more than 45 publications in neurological rehabilitation, but I would like to bring in some of the key researches that we did in rehabilitation of stroke survivors. So in the hierarchy of evidence, we had pretty much publications and studies done in almost all of them, except for meta-analysis. We also had a randomized controlled trial. And I would like to share my 2 cents as to how we were able to utilize the data and research to possibly apply that on practical implications as well. So let's put it that way: 7 questions, 7 researches, many answers, more questions. So the first one is how we can screen depression in stroke survivors with aphasia. What are the factors that affect length of stay and functional outcomes during stroke rehab in a Saudi setting? Are medical complications during stroke rehabilitation any different from the rest of the world? Does stroke itself cause a contributing factor in a knee injury? Which one is superior? I would imagine our physiotherapy colleagues would be interested to know. Is the posterior leaf spring AFO or the carbon fiber FFO? And why post-stroke falls occur in inpatient rehab setting, and how do pediatric stroke survivors do with inpatient rehab? There are a few more, but I thought this would be interesting to share here. So the first one was how we can screen depression in stroke survivors in aphasia. So we did a study on translation and preliminary psychometric evaluation of stroke aphasia depression questionnaire. And the prevalence of post-stroke depression is around 60%, maybe more. And aphasia, 1/3 of the patients with stroke have aphasia as well, and there's established association of aphasia depression too. Interestingly, the tools that are present and currently practiced, like HADS or in the family medicine, there's some screening tools available. All depression screening tools are conventionally interview-based. So you have to have a patient to talk or communicate to a certain level to be able to screen depression objectively, which, if we consider that 30% of the stroke survivors, they would have aphasia, it would be very difficult to kind of establish that. And in many of our practices, we end up just guesstimating based on our observations. So we found out, and this has been one of the most challenging aspects of our practice in rehab. So we found out that in 1998, there was already an established tool, but there was no Arabic translation. There are multiple linguistics translation available. So we thought, okay, we're going to go and try to translate and culturally adapt the questionnaire into Arabic. And we followed the established cross-cultural adaptation guidelines as well, and we tried to apply that. We applied that in 35 adult stroke survivors in aphasia. Now, for those of us who have done previously a validation tool study from a different language to a different, or let's say Arabic language, would know that these are the different steps from 1 to 10 that have to be done to validate, to possibly get a publication and establish validity of a stroke, of a language-based tool. So we were able to do all the steps except for the actual validity because of some operational and logistic challenges. We had to deviate from the standard protocol per se, but we were able to culturally adapt and establish internal consistency, reliability as well. So hopefully if this study gets published, that can have an impact. We would have a resource tool that we can introduce as a preliminary screening tool. I won't say a validated tool, a preliminary tool which can help to standardize screening of depression in stroke survivors. That is important. We try to advocate when we submitted the study for research that almost 500,000 of people in the world are Arabic speakers. There are mass migrations going on and in the European and non-Arabic speaking countries. So that can help to establish diagnosis and treatment of post-stroke depression and aphasia. Personally, this study is very close to my heart because of the value that it can potentially bring to our Gulf region and practice as well. Moving on, effects of length of stay and FIM scores during inpatient rehab. So this is the study then when accreditations were kind of talked about. JCI was a new name, sort of a new name, and CARF accreditation and other accreditations were coming over. And then we started talking about KPIs a lot. So, so this study was done back in 2010 to 2011. We had very few patients admitted over a period of 1 year. And it shows that patients who have a high functional scores at admission would largely have to have a high functional scores at discharge. And shorter the length of stay during the acute stroke care would have a shorter length of stay in rehab. Now, this is not a super science, but we wanted to establish this and document this because there was no study done previously for that. And as you can imagine back then, it's good to see the familiar faces from KFMC. You know, back then in 2010 and 11, our length of stay in acute care was even 22 days. Now we have a you know, CTU pathway as well. And rehab length of stay was around, you know, 49 days. So just to give you a background to how, you know, an inpatient and a stroke care pathway operates internationally or in, let's say, in a standardized manner, and so is at KFMC as well. Patients coming from emergency go to acute stroke unit, or they go to other hospitals in the community setting, or they can be discharged home to different disposition venues, or they go to inpatient rehab as well. From inpatient rehab, we do receive patients from other hospitals, and then they can go elsewhere. The one consistent requirement is rehabilitation, which is a core intervention as well. So when we kind of figured out that, you know, where we need to work based on the finding. So that's all around the acute stroke unit and acute stroke services, because the shorter the length of stay in acute stroke unit, the shorter the length of stay in inpatient rehab. The higher the function gains we achieve in the acute stroke unit, the higher the functions would be in the inpatient rehab as well. So impact on our practice, we figured out that what we need to do, because the National Stroke Service and the clinical pathways were already under process. But from a rehab perspective, from experience base, we figured out that major challenges, especially in our health setting, is basically social challenges, continuity of care challenges, disposition challenges as well, right? So we kind of tweaked our practices. There's a lot of psychosocial, a lot of cultural influence in stroke outcomes. So we kind of changed our practice that, you know, we introduced pre-admission family meetings as well. And the patients, when they were admitted, we did a family meeting with them at admission and prior to discharge. So this is, I think, that created a better outcome along the two domains. So this is after 10 years. I was digging out my presentations from KFMC as an annual report. So you can see that after 10 years, we were able to reduce the length of stay up to average 32 days. Now, for inpatient stroke rehab program, this is a guesstimate. or you can say an estimate, for every 1 day reduction in average length of stay rehab, the hospital saves approximately $500,000 Saudi Riyal per year. Now, this is based on, let's say, a 15-bed unit where the average cost is around 200 to 3,000 Saudi Riyal per day. And if you reduce the length of stay from 48 days to 32 days for rehab setting, the hospital saves approximately 6.4 to 9.6 billion Saudi Riyal. So this was more of an estimation, but we wanted to document one of, you can say, the tips of an iceberg. So we did a study on delayed discharges, not only stroke, but holistically as well, over a period of 6 years. And out of 2,200 discharges, almost 1/4 were delayed. That costs to about 21,000 hospital bed and approximating a cost of 80 million Saudi Riyal. So this is the hidden cost that we are not able to capture. This is also the hidden value that we are adding when we are focusing on the KPIs, and that's one of the reasons that KPIs are there. Now, moving on to our medical complications during rehab of stroke survivors, any different from the rest of the world? So we estimated, we kind of did a chart review, and we figured out that these are the common rehab complications. Not all of them are stroke-related complications. The list is longer, but commonly which can impact our rehab services. And when we compared that with the data, we figured out that our percentage of complications was actually less. So we were in a limo that, is it something we have established as a good finding, as something to be proud of? But we figured out that there was a major limitation in our study, which was that if we need to know the exact extent of problem or post-stroke complications, we have to screen better and we have to document better as well. So largely, I guess we were not, because this was a retrospective chart review, so we were not able to screen and document patients appropriately. And this is where, the EPIC came and, documentation got better and screening got better as well. So is stroke itself a contributing factor in knee injury proneness? People would not think about it that, I remember we had one lady, she was in her early 60s. And she was about to go home. She was very well in terms of ambulation. She was modified independent. She was walking with a cane. And one fine day, 2 days before discharge, she thought, I will just enjoy the grass and I'll walk on the grass with the help of a stick. It was uneven surface, and she sprained her ankle and had an ACL tear. She stayed with us for another 6 weeks with the total or maximal dependency as well. It may not sound very, scientifically challenging to see, what's a big deal that if somebody sprained their knee and had a ACL tear. But this is a non-impact injury. There's no head trauma on it. So we wanted to figure out if it's stroke itself is causing any contributing factor. And we came across some interesting literature review. Number one, female gender is more prone, as in the case of our study. Then hormonal concentration. Our data search showed that the patients with stroke, they could have decreased growth hormone and testosterone levels, and corticosteroid increase as well. All can predispose laxity and joint injury as well. So neurocognitive factors, patients may have poor judgment, they may have neurovascular factors, and extrinsic factors in her care. In her case was the footwear, and she was a bit excited to walk on uneven surfaces and sprain her knee. So impact of her practice. Now, any patient that I see with a stroke survivor walking in, I kind of have to look at their shoe wear as well. And we want to improve their compliance to therapist recommendation. And I tend to use this example quite a lot to share it with the patients that, hey, I had one case, she sprained her knee and so forth happened. Which one is superior in stroke? So we did a head-to-head trial between a carbon fiber AFO and a posterior leaf spring AFO as well. I'm sure that would be of interest for physios as well. Interestingly, when this trial was established, we figured out there is no trial done on the head-to-head with both AFOs. Yes, it was done in cerebral palsy as well, but not in stroke survivors. So we randomized the patients into 2 groups. And our results show that both improved the walking ability. So we had different gait analysis parameters as well. I'm just going to share the positive findings. Both AFOs provided a higher level of user satisfaction. Okay, I mean, this is what we commonly observe as well. But when it comes to self-selected walking speed, when you ask the patient to walk at their own convenience, carbon fiber AFO was found to be better and better in functional mobility as well. So I hope it lays a foundation for future research, and it can hopefully secure some position in some guidelines in the future. So why falls occur in inpatient rehab setting? Now, we published a study, we did a data analysis and found that almost 1/4 of the patients had fall in stroke survivors. Most falls occur during admission, during daytime, by the bedside, unwitnessed. Now, this is not something which could be potentially very acceptable, because patients are hospitalized for the reason of 24/7 medical and nursing monitoring, right? So that brought our attention to the fall prevention program. And as a part of the fall prevention committee, before I left KFMC, we worked on it for 1 year, and we came up with some recommendations along those lines as well. So this is something that we try to advocate, because when it comes to falls, it is generally considered that, this is not a medical thing, this is not a physician-based thing, or this is probably a nursing or a therapist thing. Fall, like anything else, like seizures, like aspiration pneumonia, like UTI sepsis, is a medical complications. And we did some infographics and physician awareness campaigns as well to bring their awareness engagement in fall prevention. So last, how do pediatric stroke survivors do with inpatient rehab? There was no study done on pediatric stroke survivors' outcome in terms of functionality. So we had a few patients around 7 years, and we found out that they don't get a chance for inpatient rehab because of many reasons: accessibility, awareness. And there was a significant gain which showed that inpatient rehab can improve their functional scores except in cognition. And it was better in hemorrhagic stroke survivors. I hope it was interesting for the audience. Thank you very much. If you have any questions, I'll be happy to take it. Yes.
Secondary for stroke. I remember a few years ago, we proposed a study for semi-electronic robotics by one of the Japanese companies for a patient who has plegia to assist them in their mobility and functional outcomes.
Right. So far, when it comes to device-based treatments, the industry dynamics operate differently. Usually there is a huge surge of public advertisement, and then they try to catch up with evidence as well, which technically should be the opposite. So the evidence is not that convincing so far, so much so that it has not been able to establish a position in any of the stroke rehabilitation guidelines that has been published. Unfortunately, the last AHA stroke rehabilitation guidelines were published in 2016. We had an update on acute stroke prevention 2 weeks ago, but we don't have, it is the same guidelines that have secured a little bit position on that. Robotics is not mentioned there. Is it the future? Yes. Now, it is being recommended for therapeutic purposes. And that is why a lot of hospitals, you see, they would have lower limb and upper limb robotics, but it has not been positioned to be provided to the patient as a take-home device. Thank you.
شكرا لمتحدثينا في الجلسة الأولى وهم الدكتور سعيد الزهراني والدكتور محمود الشنقيطي والدكتورة حنان الحازمي والدكتورة ابتهال الوزنة، بإدارة الجلسة من الدكتور عبد الرحمن الحربي. وشكرا أيضا للدكتور أحمد ظهير قريشي الذي قدم ورقة من مدينة الأمير سلطان بن عبد العزيز للإنسانية. أما الآن نستأذن الحضور بالسحب على الجوائز والمقدمة من صندوق الطلاب، وسيكون اختيار الفائزين عبر الكاميرات المتحركة. الفائز الأول ننتقل الآن للفائز الثاني. الفائز الثاني الآن الفائز الثالث أو الفائزة الثالثة. ألف مبروك. الآن الفائز أو الفائزة الرابع. الآن الفائز الخامس أو الفائزة الخامسة. ألف مبروك. الآن الفائز السادس أو الفائزة السادسة معنا في هذا الحفل والأخير بإذن الله. ألف مبروك. نأتي الآن لختام الجلسة الأولى وما صاحبها من أوراق علمية وجوائز واستراحة لمدة ربع ساعة. نعود بعدها بإذن الله تعالى لاستكمال الجلسة الثانية في هذا المؤتمر والتي تحمل عنوان مستجدات علاج السكتة الدماغية والرعاية السريرية. بالجلسة الثانية لليوم الأول، والتي تحمل عنوان مستجدات علاج السكتة الدماغية والرعاية السريرية، وتتناول أيضا عناوين عدة، منها التطورات الحديثة في إدارة السكتة الدماغية الحادة، وأيضا المبادئ الأساسية للعلاج الدوائي والتداخلي، وأيضا الأسس العامة للتدخلات الجراحية في حالات السكتة الدماغية، وأخيرا المبادئ الأساسية للتغذية العلاجية بعد السكتة. ندعو رئيس الجلسة دكتور فيصل بن سعود الكثيري لبدء الجلسة.
السلام عليكم ورحمة الله. الجلسة الثانية هي عبارة عن تحت عنوان مستجدات علاج السكتة الدماغية والرعاية السريرية، بمتحدثين دكتور محمد عيد العتيبي، دكتور ناصر ضيف الله العتيبي، بروفيسور هارون شاودري، الأستاذ الدكتور عبد العزيز العثمان.
السلام عليكم ورحمة الله. أولا أشكر جامعة المجمعة على هذه الدعوة للمشاركة في هذا المؤتمر. So I will talk about recent advances in acute stroke treatment. So 3 decades ago, stroke was considered non-treatable disease, and usually the treatment was focused in rehabilitation and stroke prevention. I will start with a story, true story happened last week. One male patient around 50 years, he came to my clinic. He was suffered from stroke 10 years ago. So he came in a wheelchair with weakness in the right side. So he is unable to walk. Unfortunately, at that time, the treatment was not available like now. In the same week, almost in the same age group, another patient was present with acute weakness in the right side with occlusion of one of the large arteries of the brain, middle cerebral artery. So he came in the golden hour, he received TBA, we took him to thrombectomy, so we removed the clot. Then next day in the morning when I am doing the round, so I met him walking in the corridor. So we can see the difference from patient suffering from a stroke, almost the same mechanism, the same disease, but the difference it is the treatment. The first patient the treatment was not available at that time, so it was not offered. And the last patient, he received the treatment either by thrombolysis and thrombectomy, so there is huge and major improvement. So this is summary of some of the new study or new RCT published in the last 3 years. We can see it is more complicated, it is difficult to understand. This is to show how much the stroke evolving in the last year, how the treatment was progressed. So I will try to cover some of the most important topic. So the history was started by the initial study, which in National Institute study, which used the TPA within 3 hours to treat acute stroke patient, and they show there is a great benefit in the function outcome. Later on, the ECAS study, which extended the time window. So this is the first step in acute stroke treatment. Later, what I think it is the new aura of a stroke, acute stroke treatment, especially in patients with large vessel occlusion. multiple RCT study was published in the efficacy of thrombectomy in acute stroke with patients with large vessel occlusion. Most of the study were published around 2015. I think this was cornerstone or most important discovery in acute stroke treatment. So, patient received thrombectomy, thrombectomy associated with significant improvement in function outcome, with the benefit need to treat almost 1 every 2 to 4 patients. I think it's one of the most significant or most efficacious treatment in the field of medicine. So after this study, so the concept time is brain was raised up. So we have to treat fast, we have to save as much as we can of brain. Later we try, multiple times, we try to treat patient in extended window, however by using conventional or non-advanced image, but unfortunately most of the study was not positive. So, but what we learned from this study, we learned the risk of hemorrhagic transformation, almost similar 3 or 4 or even after 5 hours. So our concern is not to prevent the hemorrhagic transformation, it is more to improve the function outcome. So later, with the discovery of advanced image, especially the perfusion study, either MRI or CT, we use the ischemic core or ischemic stroke core and penumbra mismatch to select the patient and to treat the patient by either TBA or thrombectomy. So another study were published to show that TBA is effective in selected patient based on CT mismatch. So the time window extend up to 9 hours. And then around 2018, 2 major studies were published in the efficacy of thrombectomy in extended time window. Now we go more, up to 24 hours. So we have a diffuse study and DAWN study which show thrombectomy can be effective in selected patient within 24 hours. Again, in this 2 study we use imaging selection. So we use the image technique to measure the mismatch between acute ischemic core and penumbra. So then another concept was raised up, image is brain. So now we know it is not only the time important, but also patient selection is important. So the goal of the new study or the extended window or the new treated stroke is mainly to protect the penumbra, to save the penumbra, and to reduce the ischemic core as much as we can. So, as I said, there are multiple topics, multiple recent trials were published in the last few years, so I will try to go through rapidly. I will talk about extended time window, 10K versus TBA, thrombectomy, large core stroke, intraarterial TBA, medium vessel occlusion, and basilar artery occlusion. So this is HOPE study. It is a multi-centric study which measures the efficacy of thrombectomy, but now they extend the efficacy of TBA, thrombolysis. But now they extend the time window up to 24 hours. So it is not only 4 hours, or 4.5 hours, they extend to up to 24 hours. However, there is some selection criteria. They use a CT perfusion mismatch to select the patient. So, and they test the efficacy of TBA versus control. So they show that TBA can be given within 24 hours with the broader function outcome, especially the excellent function outcome, with a little bit raise in the risk of symptomatic cerebral hemorrhage. So I think in clinical practice we can use TBA in some selected patient up to 24 hours. So now we'll go another topic, the use of 10K versus TBA. Why tenecteplase? Because why we not just to use TBA? Because the tenecteplase has more advantage in acute stroke. Has a longer half-life and can be given in single bolus administration, which can reduce the time of patient transfer or for further management. So this is major. This is the initial study, which non-inferiority, which examined the efficacy, compare the TBA with the TNK at dose 0.25 milligram, and show again non-inferiority of a TNK compared to TBA in treatment of the stroke in golden time window up to 4.5 hours. After that, multiple RCT came out, but now they examined the extended time window up to 24 hours by using a TNK. We can see, I think, more than 5 studies. Here is the summary of the study. We show some of this study use a TNK with thrombectomy, some without thrombectomy, some with use CT perfusion, a mismatch for selection. But all of the study, they use time window 24 hours. So some of them are positive, some of them are not significant. So if we take the meta-analysis of this study, so meta-analysis show TNK can improve the extant function outcome slightly, but not affect the function independently. This is mean patient not affect the ability of patient to walk. Without increased risk of hemorrhage. Okay, here is the new guideline for which published in 2026 for the use of TNK. The recommendation to be in acute stroke within 4.5 hours, either TNK or TBA can be used. So now we move to another topic. We know almost 25% of patients present with large visual occlusion also present with large ischemic core. This means patients have large ischemia. So if we look back to the initial study, they by design, they exclude the patient with large ischemic core. So in the last few days, multiple trials were published, multiple RCT, almost 6 trials address the efficacy of thrombectomy in patients with large ischemic core. So the summary of the trial, I think most of them, they use 24 hours as a time window. However, I think the most important here, the most of the trial use CT imaging, only CT imaging for patient selection. The majority of the trial, the study were positive. So the meta-analysis of this study show that thrombectomy is effective in improving the function outcome in patients with large ischemic core within 24 hours. With a slightly increased risk of cerebral hemorrhage. Again, this is the final recommendation. So thrombectomy nowadays, we know thrombectomy can be used up to 24 hours in patients with large ischemic core, especially, we can specify special patient with the aspect from 5 to 2. However, patient with aspect 2 to 0, I think thrombectomy is reasonable. So we can see how much the treatment stroke was advanced. We start first to treat patient with reasonable ischemic core, and now we expand to large ischemic core. Again, when we take the patient for thrombectomy, so the objective is to reach final recanalization, complete recanalization or near complete recanalization. So what is called TIC score from 2B to C. So sometime about around 25% of patients usually do not achieve this complete recanalization. So what we do to improve the recanalization rate? So either by enhanced thrombus removal technique or by use intra-arterial TBA. So the last one, the intra-arterial TBA, was addressed recently by 2 or 3 studies, 2 RCT. The first is shows the study which use TBA, intra-arterial TBA, at dose 0.25 after successful thrombectomy in patient within 24 hours. And the second study is barrel study, which again uses the same dose, but in the time window up to 12 hours. So this is TBA after thrombectomy. So the meta-analysis of this study shows that intra-arterial TBA after successful thrombectomy can improve the function outcome, measured by MRS, function outcome after 3 months. This means patient can improve the mobilization and reduce the morbidity. This again, the recommendation, we'll go fast. Okay, now we talk about different category of patient with ischemic stroke. So what we discuss is patient with large vessel occlusion, either patient with occluded internal carotid artery or medial cerebral artery. But sometimes we face a patient with distal occlusion, patient with distal artery occlusion. So what we do in this case, we have 3 options, either by medical treatment or endovascular thrombectomy or sometimes by intra-arterial TBA. So recently, endovascular thrombectomy was addressed in a new RCT. So we have two studies recently published, SCAPE, AMEVO, which examine the efficacy of thrombectomy plus medical care versus medical care in patients with medium to small vessel occlusion. They use time window up to 12 hours. The second study, it is distal, it is almost similar, but they use time window less than 24 hours. So, in total, if we take 2 studies, there is no clear added benefit of thrombectomy to medical treatment in patients with medium to small vessel occlusion. However, there is also increase in the risk of hemorrhagic transformation. So the new recommendation for patients with distal and small and medium vessel occlusion, the thrombectomy was not recommended. However, there is some exception in patients with dominant medial cerebral artery, M2. So thrombectomy in this case may be reasonable. Finally, I think this one of will finish in this after this topic. It is basilar artery occlusion. We know basilar artery occlusion usually associated with poor prognosis if not treated, and very high morbidity and mortality, which can be reached up to 90%. We can see here in the left, this is a new real case. 1 month ago, patient present with coma with occlusion of basilar artery. So we took him to cath lab. We remove the thrombus we used aspiration technique, so we can see how much the artery was recanalized and brain was perfused. Later on, the patient improved. So in case of thrombectomy, in early 22 studies were published, BEST and BASIC, which was not clearly positive. Later on, recently, I think in this year or the last year, another trial, Bosch trial, which tested the efficacy of thrombectomy in basilar occlusion, which show significant improvement. However, again, there is a selection criteria. They use NIH 10 or more for select the patient, and there is imaging criteria with posterior aspect more than 6 points. Another study, attention, it is used the same selection criteria, but however with shorter time window, less than 12 hours, and they show significant improvement in outcome, in function outcome after 3 months, with slightly increase of cerebral hemorrhage. So finally, the recommend for basilar artery, the new 2006 American Stroke Association recommendation. So patient with basilar artery occlusion, thrombectomy is recommended in patient with NIH-10 and present with 24-hour and with posterior aspect more than 6. However, when okay. So, in conclusion, most important, we have to remember time is brain. So, as fast we treat, as much we save brain and improve the functional outcome. Endovascular thrombectomy still remain the cornerstone in acute stroke treatment. Time to reperfusion remain critical. We have to shift the patient as fast as possible to receive the treatment. Thrombolysis strategy are evolving with time, and I think it will continue evolving. Patient selection and imaging key are important in acute stroke treatment. Thank you.
Thank you very much for your talk, Dr. Mohammed. Now we will proceed with Professor Abdulaziz Al-Athman, the President of the Saudi Society for Clinical Nutrition, for his talk about fundamental principles of therapeutic nutrition after stroke.
السلام عليكم ورحمة الله وبركاته، أسعد الله مساكم بالخير. شكرا دكتور ناصر العتيبي أعطاني وقته لارتباطي بعيادة في الرياض. Thank you for inviting me, Majma'ah University and the scientific committee, Dr. Abdulaziz. Thank you for all people actually inviting me to this talk. May I have my presentation? I will just summarize some points. Actually, most of the slides that I'd like to talk about being discussed this morning by Dr. Saeed, Dr. Abtihal, Dr. Mahmoud, Dr. Hanan. And so I don't need actually to do too much about these things. But I will try to highlight some points that treating the stroke is not only focusing on one disease, but actually we have to treat the other morbidity at the same time. So very important actually to emphasize an assessment and treatment in general, and also treating with the stroke. And I'd like actually to remind all health professionals to emphasize on the assessment, ICD-10 or ACHI, because we face some difficulties in classification of diseases. So now, if we'd like actually to treat a disease, we need actually to assess, to diagnose that disease very well. And you see this, a lot of diseases, with morbidity, either psychological or physical diseases need to be considered with the stroke. So as you know, the person who has stroke will be affected even psychologically or also physiologically, cannot eat very well. Sometimes they may have some deficiencies of nutrients, not due to absorption, but due to intake, and difficulty to swallowing or having difficulty with using his or her arm, even losing of some memory, and sometimes feel hungry or anxiety, depressed. So also if they have another comorbid disease like obesity, most of these patients, unfortunately, they lose weight, especially when they started in ICU. Unfortunately, 70% of patients in ICU, they suffer from deficiency. Again, don't listen to social media when you talk about any disease. We need actually to remind my beloved students here to depend on evidence-based medicine, evidence-based practice. Don't be judgment. Don't say, okay, I think this is like this. No, we have to be precise. So we have to depend on guidelines. Many people talk about studies. Yes, in conferences, we'll talk about studies. But in medical health or practice, we don't depend on studies. And somebody on social media, somebody tell us, okay, we have studies saying like this. I have 50 studies saying smoking is good. So in medical practice, we don't depend on studies. We depend on guidelines. We depend on real assessment. We are talking about something called personalized medical nutrition therapy. Do you know what is personalized medical nutrition therapy? We need to personalize assessment, diagnosis, and treatment. But personalized medical nutrition treatment saying there is no more RDA. Do you know the RDA, how much nutrients you need every day? These will be stopped within 5 years. I have to personalize your needs because you have, genetically you have different requirements. So I have built my treatment or assessment in your situation, not other situations. Multidisciplinary team, also we have to emphasize on this. To treat stroke or other disease, we have to work as a multidisciplinary team. Lifestyle modification, I think been discussed by Dr. Saeed and Dr. Mahmoud this morning, and we'll emphasize on it many times. It is not the bill of drugs that will treat you. We have to think about lifestyle modification in prevention of stroke and how can this patient accommodate after that. They need a lot of support. They need a lot of recommendations to modify their lifestyle. Please don't forget quality of life. Sometimes we request this having stroke, for example, to have cholesterol, not 5.2, maybe 1.2 or 0.5, according to the guidelines. But we have to consider quality of life. يعني هذا الشخص اللي جاي ستروك عنده 20 مشكلة، إنسان يعني إيجابي وفجأة فقد كل شيء، هو يظن إنه كذا، فهي or she need your support to approve this. The second point, I see many people, they don't use the standardized assessment. They use just height and weight and some vital sciences. No, we have malnutrition assessment protocols. One of them, NARS 2002, and must, and you can download it if you like. You just see the QR code if you'd like to download this nutritional risk screening. This is the must, which is very easy. Sometimes you tell me that this patient having malnutrition. What I should do with this having malnutrition? I don't understand what does it mean. But in these procedures or protocols, we have classified, is it mild or severe? What sort of procedure I can do? We have only one and 2 and 3, and you can tell me what's the severity of malnutrition that I can do. This patient need to be hospitalized or need just add some supplements. The one I spoken actually the Minister of Health about introducing GLIM. GLIM, it is like leadership initiative to have classification of malnutrition to fit with all diseases. It's easy actually to have dietary counseling, but you need actually sometimes to fortify some foods or give some supplements. I think Dr. Mahmoud told us today we don't need for stroke to have vitamin B complex or omega-3 as supplements. But sometimes we need to go to enteral or parenteral nutrition in these patients. Even in enteral nutrition, we need to use nasogastric or BEG. Many people, many parents or many families, they reject BEG because they feel that it's difficult instead of the nasogastric. But in fact, for long-term patients, we have to start BEG for these patients. This is the Saudi standards for stroke. As you see, this is the multidisciplinary team that required to treat these conditions. This is the guidelines. Unfortunately, it's not the recent one, but this is the available guidelines talking about we have to improve the dietary and lifestyle practice, both at the same time. So this is just give you just a brief about what type of dietary we have to do. One of them in enhancing to have all major foods. There is no magic foods. There is no special magic foods. يعني كثير من الناس يقول والله إيش هي الدايت اللي will give me to treat this disease. We don't have. All what you need to have to eat from all types. يعني all those people talking about diets, just forget them. يعني كثير من الناس يعني يتكلمون عن this is keto diet, this is intermittent fasting, this is don't take breakfast. This is no evidence-based evidence on these. So don't listen to them. Also, having a body weight. All people like to lose weight. But at the end, unfortunately, they are talking about diets. Again, no diets, please. Lifestyle modification is enough, actually, to improve the weight reduction for all people. But those with the stroke, they may need a special treatment, actually, to cut some of calories. But also, we need to use the word physical activity. For your patient, don't tell your patient, especially older people, do exercise. يعني واحدة عمرها مثلا 50 سنة 60 سنة تقول لها روح يسوي رياضة. إيش رياضة؟ إيش يسوي رياضة؟ No. We are using physical activity, improve user physical activity. Not for this patient, even for us. يعني تحاول تتحرك تستخدم الدرج تمشي شوي يعني. This is what we need instead of special exercise. Also desirable cholesterol level. This is very important, as also mentioned by previous speakers this morning. And I will give you an example of this. Desirable blood pressure. Very important, actually, to refer your patient to the dietitian, because they can train the patient on something called DASH diet. Do you know DASH diet? So DASH diet is a diet, classified or designed to stop hypertension. This is that DASH diet. You can find it in a place. Just think about this is the DASH for hypertensive and stroke patients. This is in a study. It's a long study, actually. It's covered more than 195 countries. And what they found? They found cardiovascular diseases, mortality, and the disability by this. 10 million and 200 million disabled. Cancer are the same. Then diabetes. Then diet-related. You see, some people may die because of deficiency or overnutrition in nutrients. 5 million. And about 177 million disability just related to diet, and also this high intake of sodium. So please, just to remind you this with hypertension and stroke. If we don't use salt only. Salt is sodium chloride, right? The problem with the sodium, what is the difference between using sodium and sodium chloride? Can anybody tell me? المشكلة في الصوديوم ليست في الكلورايد. Why we should use sodium instead of sodium chloride? Because they presented preservation of products. يعني في شيء اسمه صوديوم بنزوات. كل المواد الحافظة صوديوم بنزوات. اللي يسمونها الجلوتامات صوديوم مونوجلوتامات اللي هو يسمى ملح النكهة ملح الصيني. This is having high sodium. And also those having low intake of whole grain. You see how many millions may die or having disability or low intake of fruits. And you can see the red one, these are having cardiovascular diseases, and they include actually stroke patients with them. How how much the percentage that related to intake, high intake of sodium. And this is the disability. What is the guidelines? Some people talk about the food guide pyramid. يعني سمعتوا انتم خلال الايام الماضيه الناس يقولون طلع لنا الهرم الغذائي مقلوب. هو ما هو مقلوب ولا شيء. للاسف اللي قاعدين يسووا interpretation of this, they don't understand what does it mean. We don't use the food guide pyramid, by the way. We use something called healthy plate. And there we have, alhamdulillah, Saudi healthy plate. So there is no change in recommendation in cardiovascular diseases or stroke, or all diseases. So we have to, emphasize on the disease and also comorbidity of the disease. This is another guidelines, you can download it, is saying the same thing, that we have to control our intake, all of us, intake of fat to avoid any dysphagia, and also to cut, or to control lipid profile in the normal. And this is the guidelines, the evidence base that we have to consider with the patient with a stroke. What are the interventions that we need? Do we need to start with nasogastric or BEG, or at the end the parenteral nutrition to prevent any deficiency of these patients? If the patient will stay in the hospital more than 28 days, we have to move to BEG. Normally we use oral feeding, then enteral feeding, and some complications. We have to start with parenteral nutrition in just a few number of patients, specific patients. But it's not preferable actually to start parenteral nutrition. Supplements, most of patients may need supplements if there is a deficiency. Don't give supplements without the deficiency of these diseases. I will just move to something very important, even targeted maybe to our students. What is cholesterol? أنا معنا طلاب وطالبات صح؟ في طالبات طلاب؟ No? What is cholesterol? Is it type of carbohydrate or protein or lipid or something else? Cholesterol. Many people may say it is a lipid, but let us say this classification of something called lipids, or so we have triglycerides. This is the first one. Triglyceride is the oil or fat that we know. So either saturated, unsaturated, trans fat, that it should be avoided with stroke patients. Omega-3, omega-6, all are fat, oil. يعني كل الزيوت والشحوم اللي نعرفها اسمها triglycerides. The second one of lipids called phospholipids. One of them is the lecithin, is the cell. The third one is called cereals. Cereals, example of cholesterol. Now I will ask my question again. Is cholesterol is fat? Huh? Yes? No. Cholesterol is not fat, is lipids. Cholesterol is not fat. The fat is triglyceride. Agree with this? طيب خلينا ننتقل للثاني. We have chylomicron. I will pass this because shortage of time. Let us just focus on HDL and LDL. Many people called HDL is the good cholesterol. Actually, we don't have good cholesterol and bad cholesterol. لكن فيما بين, just to understand it, yeah? For those having high risk. This is high density. High density because it has too many, 50% of protein. And the cholesterol is 20%. احفظوا هالرقمين. High density, 50% protein, 20% cholesterol. هذا HDL. But LDL having 45 maybe cholesterol and less protein means LDL having more cholesterol. So the question number 2, is LDL cholesterol? No, it's not cholesterol. LDL is lipoprotein, but it's carrying cholesterol, too much cholesterol, while HDL carrying little cholesterol. We agree with that? Okay. Now what's happening? All are important. LDL is transferring the cholesterol from liver to tissues, and HDL transferring cholesterol from tissues to liver, then get rid of it. كلهم مهمين. يعني أنا أعرف cholesterol is the precursors of 6 hormones and vitamin D. All of them are important. This is for normal people. But what happened to those having stroke or cardiovascular disease? We have to control LDL to minimize LDL and increase HDL. How can we minimize LDL? Do you know? By avoid food that rich in cholesterol. لأن احنا ما نبغى الكوليسترول يتخزن داخل الخلايا، لأن هذا عنده هايبر كوليستروليميا. الشخص الطبيعي ما المفروض ناكل كل شيء طبيعي، ناكل دهون، ما عندنا مشكلة. المشكلة ليست في الدهون، المشكلة فينا احنا فقط. But for those having stroke or cardiovascular, I have to lower the cholesterol in the tissues. طيب, how I can improve or increase HDL? There is no relation with diet. It is moderate exercise. So HDL, to improve it, there is no link to diet. So to do this, at the end, I have to control LDL because it's having high risk of, risk of heart attack and also stroke. These are the high cholesterol foods. To avoid, to minimize LDL, avoid this. ترى سويتهم بالترتيب. لأن كثير من الناس أول ما يقول I have to drink skimmed milk. Yes, skimmed milk is good. يعني الناس اللي يقولون يا ناس اشربوا حليب كامل الدسم هذا غير صحيح. الناس اللي high risk they should stop all fat or minimize خلينا نقول. لكن لا توقف على الفات فول فات تروح تاخذ سكيم وانت تاكل من المطاعم ولا تاكل كبده مرتين في الاسبوع. Because the percentage of cholesterol in the top line is 5 times than milk. So I have to avoid this. And also I can eat some foods that minimize or reduce cholesterol. This is for all of us. Because as you know, 60% of cholesterol is built in our body. 40% will depend on food. And when we talk about stroke, we focus on cholesterol, we forget triglyceride. I believe that saturated fat is more dangerous than cholesterol. So it's not a matter of cholesterol. Also, I have to focus on this high, saturated fat with the yellow line. either coconut oil. كثير من الناس زيت ايش؟ جوز الهند. يعني some people they drink it, they eat it, they use it because I don't know why. But anyway, we have to focus on this. We should not forget the antioxidant, quality of life, healthy life, and also now, alhamdulillah, we're using AI in nutrition to predict any risk on cardiovascular. يمكن الدكتور ابتهال والدكتور سعيد اليوم معنا في عندنا صح virtual hospital. We have a program about this, but not the time actually to talk about it. And finally, we have to think about lifestyle medicine. Lifestyle medicine, how to have balanced diet. Not 100% healthy diet, no, balanced diet, balanced nutrition. Physical activity, not important to be exercise, cessation of tobacco, controlling of stress, quality of sleep, quality of good relations, and they add before maybe 8 months to exposed to the nature. يعني يطلعوا للشمس للبر they found in exposure to sunlight is not only prevent vitamin D, but it's part of our life. Anyone interested actually to support in intraparental nutrition, we have a group of called SABN, Saudi SABN, to support any hospital need training or that related to nutrition for those stroke, and you can contact me if you like. So, and thank you very much.
Thank you very much, Professor Abdulaziz, for mapping the principle of therapeutic nutrition options for stroke patients. Now we proceed with Professor Harun Chowdhury. He's the consultant neurosurgeon at Hudson Neurosurgery Institute, New York, for his speech about general principles of surgical intervention in stroke cases. Please.
Assalamu alaikum. Good afternoon. It's a great honor for me to be here. I'd like to thank the organizing committee, and especially Dr. Faisal, for extending the invitation and giving me a chance to talk with you all. We've heard a lot today, very good information about stroke from all different specialties, and I think that's going to be the theme of my talk, how neurosurgery is a member of the team in taking care of stroke. I came to be interested in stroke early on, doing research with creating strokes in rats, doing little rat craniotomies when I was a medical student. And then when I went into practice at the University of Georgia, we had a very busy stroke center, 3 full-time stroke neurologists, stroke ICU, 2 helicopter pads, and we had patients coming from all over. And we had sort of a microcosm of the situation here in Saudi Arabia where we had a very good stroke center, but a lot of small clinics and hospitals in the farming areas and rural areas of Georgia where delay to treatment was a big problem. Actually, our university was one of the first to do a telehealth for stroke, and they're the originators of the REACH program to do telehealth to evaluate stroke, to consider whether to give TPA. But I'm going to talk about neurosurgery and how neurosurgery is involved in stroke. And some of you may be wondering, how is neurosurgery involved? Well, we're actually a member of the team in all aspects of stroke care. We're a member of prevention, diagnosis, acute management, reconstruction, and then there's a burgeoning field of neuroplastics, and even in rehabilitation, neurosurgery has a role. Although, you know, I come to this meeting and I've learned today, I saw some very impressive stuff this morning about pre-hospital care and pre-hospital CT scanning. That's amazing. There is no pre-hospital neurosurgery yet. So that's not one part of our group. But what about prevention? Okay, we've heard a lot about the different modifiable risk factors, a wonderful talk on nutrition right now, and all these other risk factors. You don't want me managing your blood pressure and giving you medications and all that. So how is neurosurgery involved in prevention of stroke? Well, we can do cerebral revascularization. Carotid endarterectomy is a great way to prevent strokes in an appropriate patient. It's beyond the scope of this talk here to talk about the exact indications. But extracranial, intracranial bypass, ECIT bypass, is another way of providing revascularization to patients at risk. That's something neurosurgery can do. Now, I'm not going to get into the fight about whether endovascular treatments are primarily neurosurgery or interventional neuroradiology or interventional radiology. That's all also part of what a neurosurgeon can contribute to a stroke management program. Now, what about hemorrhagic stroke, especially subarachnoid hemorrhage? Now, we all know that the most common cause of subarachnoid hemorrhage is trauma, and then aneurysms, and then AVM. In children, it's trauma, AVM, aneurysms. But for aneurysms and arteriovenous malformations, neurosurgeons have a role to play in helping to control and prevent rupture of these structures. So that's another preventive aspect of stroke. Might not be thought about in the traditional way. What about diagnosis? Now, we've heard this several times today, time is brain. And it's very important when we talk about metrics like door to CT scan time, door to needle groin time, It's also important for the patients who wind up needing neurosurgical intervention that we track door to neurosurgery consultation time. Getting neurosurgeons involved early can lead to better management. And I always talk about the ABCs of emergency care. Neurosurgeons are very simple people. For us, the ABCs are airway, breathing, CAT scan. Get the CAT scan as fast as possible because that's going to help guide what we're going to wind up doing. Now, there are different pathways based upon primarily the imaging. Knowing whether you have a hemorrhagic stroke or ischemic stroke, big difference in terms of blood pressure management, giving aspirin. If you have a subarachnoid hemorrhage, you really don't want to raise blood pressure or give aspirin. If you have a hemorrhagic stroke, you also don't want to raise the blood pressure. But in ischemic stroke, you want to make sure you avoid hypotension. It's all about protecting the penumbra. Now here's an example of a stroke. I think most of us can see over here, there is a large MCA stroke on the left side. You see some mass effect. The ventricles on the left is squished, pushed over. There's actually some midline shift there. So that's an ischemic stroke. This is another ischemic stroke in the posterior fossa. And you can see a stroke back here with effacement of the fourth ventricle. That's a really key finding because that can lead to hydrocephalus, which you can see the temporal horns of the patient earlier in an upper cut of the CT scan. Now, posterior fossa stroke, the important number to keep in mind is 3 centimeters. If there's a 3 centimeter hemorrhage or ischemic stroke in the posterior fossa, it probably should be treated neurosurgically. So if you see this kind of picture, at the very least, you're going to wind up putting in an external ventricular drain, and we'll get to that when we talk about acute management, but probably posterior fossa decompression. If you don't involve neurosurgery early, and you say, okay, this is a stroke, it's not that big, the patient's awake and talking to you perhaps, we'll see in the morning and then we'll decide after rounds whether or not to consult neurosurgery. That's too late. This is the kind of patient who should be considered for operative intervention. A really good grade patient who's awake and talking to you, even with a 3 centimeter ischemic infarct in the posterior fossa, you can try to get lucky and wait on the patient if they're in an ICU and if there's immediate access to neurosurgery. Neurosurgeons on call, they know the operating room has the capacity to do an emergency craniectomy in the middle of the night. Otherwise, this should probably be referred for surgery. Now here's a subarachnoid hemorrhage. Typically, again, aneurysmal subarachnoid hemorrhage, but that's another type of stroke that has to be kept in mind. And certainly you don't want to maintain blood pressure in these patients because you can cause a re-rupture. Acute management, I already referred to external ventricular drain. ICP monitoring is also something neurosurgery can offer by placing these monitors. That allows us to maintain CPP, cerebral perfusion pressure. And the simple formula for that for the med students is mean arterial pressure minus intracranial pressure equals CPP. And you want to keep your CPP typically above 60 or so. With barbiturates or cooling or propofol, you can sometimes tolerate it a little bit lower. But maintaining the CPP allows you to rescue penumbra. And again, we talked about different ways of thrombectomy, which is amazing. You know, that wasn't available a number of years ago. But you can also rescue penumbra by maintaining perfusion of the brain and oxygenation. Decompressive craniectomy, I already talked about posterior fossa. When it's 3 centimeters or more, decompressive craniectomy can be life-saving. Hemicraniectomy is also good. So a patient with a middle cerebral artery infarct, I'm going to show you in a second what that looks like. And then, of course, acute management of aneurysms and arteriovenous malformations is something else neurosurgery can help with. So here's a patient with a, again, left MCA stroke. And you see on the right side of the right image, the brain, the skull has been removed and the brain's allowed to swell. Now, the effect of that is instead of having pressure on the ventricle and midline shift, the midline has come back and the ventricle is reinflated. But the real advantage of doing a decompressive hemicraniectomy is that penumbra tissue is saved. The intracranial pressure of that tissue is decreased by allowing it to swell out. Some of that tissue is going to become infarction and is not going to survive. But you keep the forest fire from spreading because if you have it here, then some penumbra becomes ischemic. Then it swells more, then there's more penumbra. Then that becomes ischemic and so on. So you want to stop this by allowing the brain to swell out there, and there'll be a big defect there. That gets into the next aspect, which is reconstruction, putting the bone back or putting something back in the place of the craniotomy flap. Posterior fossa decompression almost never needs reconstruction, but supratentorial decompressive hemicraniectomies or large defects, typically we need to put something back there. Now, there are all sorts of things that can be done. People use pieces of rib, they use methyl methacrylate and other synthetic materials. It's hard to get a good reconstruction of the cranial vault with synthetic materials. You can do it with plates and so on, but the real gold standard now is to use titanium. And this is an example of some 3D printing, which is how they make the modern cranioplasty implants. Now, we don't have, this is showing mostly spinal implants, but it's showing the 3D printing process. What we do is we get a CT scan with bone windows, and we make a mirror image of one side of the skull with the other. So you can wind up creating a 3D printed, customized patient flap and put that back in place. And that's something which is very helpful for the rehabilitation of the patient. Because and neuroplastics is the idea of making neurosurgical intervention less cosmetically unappealing, paying attention to incisions, scarring, hair loss along the incision, poor contouring of the skull, tissue loss, and so on, in addition to the neurologic recoveries. When it comes to rehabilitation, here's an example of a 3D printed flap that's attached in place. When it comes to rehabilitation, patients we find have better neurologic recovery when you put the cranioplasty flap in or craniotomy flap back sooner. Something about the resonance of the brain within the fixed cavity allows it to recover faster. Obviously, in the acute phase, when the brain is swelling out and the skin is tense, that's not a time to put a craniotomy flap back. When it's sunken in, then it may be ready. Now, there are trade-offs, as there are in many things in medicine. If you do it too early, you have a greater chance of infection, especially if you're putting the same bone flap back. If you do it too late, there may be delayed neurologic recovery. So now with the modern materials, you can put in a lower infection risk device without having the problems, and you can do it earlier as soon as the brain has settled down some. Another aspect that neurosurgery can help out with in terms of rehabilitation is with spasticity. And intrathecal baclofen pumps have been very useful for many patients. A bit costly, but for some patients that can't tolerate oral baclofen because they become too sleepy, but they have a good response to intrathecal injection, intrathecal baclofen therapy is a good way of taking care of them. Thank you very much.
Thank you very much, Professor Chowdhury, for talking about modern options of neurosurgery management for stroke patients. Now we proceed with Dr. Nasser Dhifallah Al-Ataybi, consultant neurologist and stroke specialist at King Faisal Specialist Hospital and Research Center, regarding his talk, Principle of Medical and Interventional Therapy. Please.
Assalamu alaikum, Masal khair. I'm very honored and privileged to be part of this elite team, and thankful for the organizations, and we hope that we discuss something that worth your valuable times. Special thank for Dr. Abdurrahman for his invitations, and I always remember قول المتنبي وقد حملتني شكرا طويلا ثقيلا لا أطيق به حراكا. سعدت وأفتخر بهذه المشاركة الكريمة منكم جميعا. So when we talk about principle of acute stroke management, the principles are dynamic, okay? So you look at the recommendation, the guidelines every time is changing. And we just recently, last 2 weeks, we have a new recommendation has changed some of the guidelines. So principle always is not a fixed, it changed based on the evidence, based on the practice, and based on the experience. And I remember when I started my training in '98, I started as an internal medicine resident. At that time, we have only aspirin for a stroke, okay? There is no data for treatment of acute ischemic stroke. Over the last 10, 15 years, the huge advances in acute stroke management has shifted the gear. Now stroke, we think we are probably 5 years behind acute cardiology. Now, when you look at the cardiology hyperacute management, it started 20 years ago with only streptokinase, then moved to TBA, then they went to something we called secondary stratification, where the patient go for angio suite, and now their primary treatment for acute coronary syndrome is primary BCA. And I believe in the next 5-10 years, every single patient with the stroke, he will go direct to the angio suite, okay? Providing we have the logistic and the facilities. Now, when we talk about stroke, this was covered by Dr. Saeed Zahrani early, the burden and the prevalence of stroke. We're talking about very common disease. We're not talking about corona, okay? We're not talking about something like Alzheimer, okay? This is very prevalent disease, and the number of new stroke per year is increasing. This is the estimation of the stroke patient who had first time stroke in 2005, and we expect in 2030 we'll have 23 million of new stroke per year worldwide. So one of the commonest highly prevalent disease in all medicine. It is the second leading death after cardiovascular disease. So it's a prevalent and it carries high morbidity and disability. So it's very fatal disease. It's number 2 after MI and cardiac, and even common in young patients. If you look at young, so stroke is not a disease of elderly. We see in our stroke unit, 50% of the patients, we see them younger than the 50 years old, which we consider they are young. So it's number 5, even in young population. So it's a very common and prevalent disorder. We think with the aging, populations now, with the increasing of the risk factor, we'll have high burden of stroke. Every 6 seconds, somebody dies from stroke worldwide. And since we started this morning, we start at 10 o'clock. How many 6 seconds passed? Come تقريبا. So maybe hundreds of 6 seconds. Huh? So hundreds of people, they died worldwide from stroke, just in the last 3 hours. So it's a very fatal and very common disorder. 6 million, they died from stroke worldwide. And by the way, the mortality of stroke, it's more than HIV, TB, and malaria together, okay? So when you see a patient with the TB and malaria, there is a lot of, media and maybe a lot of work done about it, and because it's very infectious and communicable disorder. But very interesting, stroke can cause more death than these common disorders that we see in many countries. This is from WHO, show you the mortality of stroke per year. So it's number 2 after ischemic heart disease, 6 million, they die from stroke. So 10% of mortality secondary to medical illness, it accounts from cerebral vascular disease. In Saudi Arabia, we have a few studies about the incidence and prevalence of stroke. They estimated that the prevalence, the incidence of stroke is 30 to 100,000, which if we extrapolate from this number, we project that every day we have 50 to 100 new stroke in Saudi Arabia. Okay, so every day, this is among Saudi population. So it's very common, and I'm sure in Majma'a and other maybe city, you see at least 1 case of stroke per day, right? We see in our hospital, and I used to work in National Guard, we see maybe 3-4 days of a new stroke per day. In King Faisal right now, we see 1 or 2 new cases in other hospitals. So it's very common disorder that you see it every day. So we want to make sure that we manage those patients very well. We at least we try to elevate the burden, and they receive the maximum treatment. So this is an interesting slide. I get it from Saudi statistic website showing you the Saudi population growth over the last 50 years. We were 6 million in 1960, in Saudi Arabia. And in 2003, 22 million, okay? And they are projecting that we're gonna be in I think, in 2050 will be 50 million total populations. And this is the age distribution of Saudi populations over the last 30 years. If you look at in 90s, most of the Saudi population, they are young, youth, the middle age. And I remember when I was in the secondary school, they were saying 50% of population that are young, less than 18 years old. So those young folks, they grow up, and we expect in 2050 that we will have very high percentage of the group, they are middle age and elderly. So we are thinking in 2050, we will have a lot of vascular burden and a lot of peripheral vascular disease and a lot of stroke. And also the recent data from MOH that the life expectancy in Saudi Arabia because of the good medical care is expanding from, I think, from 70 to 74 right now. So with the aging populations, we think we will have more of vascular disease. So Dr. Saeed, he talked today about the concept of mismatch, and this is an important concept. Anyone who's treating stroke, any neurologist, they must know this concept. And this is important because the way we triage our patients in acute care is depend on this concept. And when you have a patient with a stroke, so a stroke is an ischemic infarction secondary to blockage of the artery. So when you have a blockage of the artery, we have 3 different zones in the brain. We have the core zone here. It's okay. So we have the core zone. The core zone is the infarcted zone. This is nothing you can do about it. It's a dead tissue. Okay? This is the one who has very limited blood supply, less than 20 or 10 of milli per 100 grams. Okay. So the dead zone or the core zone, it's that we see on CT scan and we see it in the MRI diffusion. So this is gun tissue. You cannot do anything. However, there is a large area of hyperperfusions around it. We call it the hyperperfusion or the penumbra area. This is the salvageable area. So this area is hyperperfused, but still viable. Tissue is still alive. So our interest as a strokeologist is trying to save this area, either by acute therapy like thrombolysis or endovascular treatment, or at least we're slowing the progress of this area by other modality like treating infection, treating blood sugars, and making blood pressure is optimum. These important things, because if you don't treat those patients, the penumbra area will progress and will be infarcted, and you cannot do anything about it. And I'll show you, this is the progression. This is cartoon show you the progression of the penumbra zone with the time of no treatment. So this is the initial one, which is the core zone. If you have very low cerebral perfusion, less than 20, you have significant area of hyperperfusions and infarcted tissue. And with the time, if you don't interfere, you will have almost all the hyperperfused area, it will be gone and it will be dead. So Dr. Saeed, he showed that time is the brain. The early you interfere, the early you save neurons. Every 1 minute goes without treatment, you lose 2 million of neurons, 17 billion of synapses, 7.5 of myelinated fibers. The brain age 3.6 years for each hour of not treating patients. So each hour goes without any treatment, your brain, get older, okay? So our interest is to interfere as early as possible to prevent the expansion of the penumbra to core or to irreversible damage. Now, there are a lot of data about slowing the progressing by neuro modulations and these things, and still there is a lot of data trying to slow the progress without interfering by opening the artery, but none of the molecules has been successful approved for that. So I want to show you a real example of penumbra in a real patient. So this is a patient who came with acute ischemic stroke. The first picture on the side or on the corner is CT scan. Usually in the first 24 hours you don't see anything on the CT scan. CT scan may be normal, okay? The second image is DWI, which is a diffusion weighted image, which you use it in a acute ischemic stroke model. The hyper intensity anyhow, the hyper intensity, you see it on the right side, we call it restricted diffusion. So the hyper intensity, the white area is the core. This is irreversible damage. You cannot do anything about it, okay? If you look down here, the perfusion area, there is significant area of hyperperfusion which does not match the core area. So we call it mismatch. There is mismatch between the hyperperfusion and the irreversible tissue. So our interest is trying to reverse the pathology by opening the artery or canalization, trying to save this tissue on the right side. So again, another example, this is a patient who has right M1 occlusion down. If you look at the MRI, there is a blockage on the right side, okay? There is significant area of hyperperfusions here, but small infarcted tissue in the upper there in diffusion weighted. So if you do not interfere early, if you don't open the artery by thrombolytic or endovascular, the rest of the area will be completely damaged and infarcted. Two different examples. This is a real example that we've seen. So the first one, patient, he came on 5 hours. He came with left side weakness. Look at the DWI here with the green. So there is small area of diffusion restriction, small area of infarctions, okay? And he has significant area of hyperperfusions up there with the red, okay? So small area of infarctions, large area of hyperperfusions. There was nothing done for the patient because he came late, or there was nothing done for him. And you can see the area to progress after 3 days. So the area of hyperperfusions progressed to infarction, so infarct already. And the patient sustained a major disability. Another beautiful example, a patient who came with 4.5 hours, exactly to the similar, significant area of hyperperfusions. You can see the diffusion restriction down and the area of hyperperfusion on the right side. He was recanalized immediately with the endovascular treatment. And look at the diffusion weighted image after 3 days. So we were able to save the rest of the area with the hyperperfusions by just opening the arteries, okay? So this is an important, and now the management of acute stroke is changed from time dependent to tissue dependent. And we're using a lot of imaging modality right now, CT perfusion and sometimes MRI, to identify if the patient, if the tissue at risk or not, okay? If the tissue is still viable, hyperperfused, probably this area is ready for revascularizations, okay? And we are extending right now the endovascular treatment 24 hours in our institute, and most of primary stroke center now, the 24 hours window is now the timeline for endovascular treatment, okay? And there are data now is going, there is a lot of data and randomized studies up to 3 days, even 3 days. So if you have an occlusion, you have a tissue that you can save, even sometimes beyond 24 hours, you can save the tissues, okay? This is a slide show you the recanalization rate. So when you have a blockage in the artery, okay, recanalization rate vary depending on the intervention mode that you use. Sometimes it recanalizes spontaneous without any treatment. IV thrombolysis open the artery 40%. Endovascular recanalization rate reached up to 75% or 80%. And that's why it's sometimes important when you have a large occlusion, even if the patient comes early, we take them to the endovascular treatment because we know IV thrombolysis wouldn't open this artery and you have to open the artery mechanical. These are the studies of timelines of acute stroke treatment studies, and you can see the progress in over the last 20 years from TBA, from mechanicals and tenecteplase and endovascular treatment. A lot of studies was positive, a lot of study was negative, and right now we're talking about even large core infarctions. There are data recent now that even if you have a core and established infarctions and the aspect from 3 to 5, maybe you were able to save even some tissue and they have good functional outcome. Okay, so this is first study was published in New England in '96 for TBA. Before that, we used only aspirin for acute stroke management. Okay, so this study is called NILS trial, was approved. It was the first randomized trial for TBA approval, and TBA was approved at that time, and I'm sure you know all the inclusion criteria. Dr. Saeed and our colleague, they mentioned the early you give TBA, the better outcome. It doesn't mean you have 4.5 hours window. If the patients come early, you have to give him as early as possible a thrombolytic or endovascular, because if you give early, the outcome is better and the side effect is less. Then TBA was extended from 3 hours to 4.5 hours based on ICAS 3 trials. And right now, thrombolytic is approved up to 4.5 hours. Okay? This is the recommendations for thrombolytic. You have to give the TBA within 60 minutes from door to needle. So we call door to needle. So within 60 minutes, okay? Once the patient comes to the triaging, so CT scan has to be done in 25 minutes, stroke team, they have to see in 15 minutes, and TBA has to be given on less than 60 minutes. Okay? Recanalization rate varies depend on the site. So if you have large occlusion in the ICA or M1 occlusion, those usually wouldn't recanalize with thrombolysis. So we usually tend to take the patient direct to the NGU suite for mechanical thrombectomy. These are the major trials Dr. Mohammed he showed us that approved endovascular treatment for 6 hours and even beyond 6 hours up to 24 hours with the help of the radiology parameters. Okay, so I'm going to shift gear and talk about something Dr. Saeed he mentioned early about mobile stroke unit. In the recent guidelines, mobile stroke unit was approved as level 1 evidence in treatment for stroke, okay? And the recommendation is very strong. If you have the ability to do mobile stroke, because it shows significant efficacy and better outcome for the patient. So in King Faisal, with the collaboration with the Ministry of Health, we have the first regional mobile stroke unit in the regions, and the mobile stroke program was established by our colleague Dr. Fahad Al-Ajlan a few years ago, and we decided to try it in Hajj, because Hajj is the largest mass gathering worldwide, okay? And there is a lot of vascular disease. So we decided this year to mobilize the mobile stroke in the Hajj area and trying to advance the care for acute stroke patients. So, I'm sure every one of you, he went for Hajj and he's planning to Hajj. So Hajj area, Al-Mashaa'ir place is very small places and crowded, okay? It's very restricted geographically. And you can assume 2 million, they are moving at the same times in very close space, and they have communicable, non-communicable disease with dehydration. And second, so we expect they will have a significant morbidity and mortality. I'm gonna skip that just because of the time. So during Hajj pilgrims, they go to different places, Al-Masjid al-Haram, Mina, Muzdalifah, and Arafah. They arrive to Mecca 7th al-Hijjah, then they go to Mina, then from there they go to Miqat, then they go to Mina, then from Mina to Arafah, then from Arafah to Muzdalifah, then they go back to Mina, then in Mina they go back and forth to Jamarat, okay? And it carries very significant obstacles and barriers, even for we're talking about nationwide, okay? Trying to manage those patients or those pilgrims in a perfect way, very challenging for different reasons. Different language barriers, restricted places. Most of the Hajjaj, they are elderly, they are having very comorbid and vascular disease. So it's very challenging and very tricky trying to provide the optimum treatment for Hajjaj. So last year, pilgrims was 1.6, this is data from Ministry of Hajj, 1.6 millions, most of them from outside, 78 non-Saudi, 18% I think they were Saudis. I'll just skip that just because of the time. See, I want to show you something. So 1.6 million in very small geographic area, okay? 100 kilo square meters, 120 kilometer. Riyadh area, 50 في 50 كيلو, so 250 square meters. I'm sure ما أدري كم المجمعة كم. So having 2 millions in between Mecca and small region Mecca, then they go to Arafah, then Mina, then Muzdalifah, and small areas, very challenging. Okay. So this is interesting data. So for each meter squared in Masjid al-Haram, 4.5 pilgrims. كل meters 4.5. Okay. See just the density of the people and the crowdness. And then comes after Masjid al-Haram, I think Muzdalifah. Muzdalifah is a very small place. Then Mina. Then Arafah. And this is another table give you for each meter square how many pilgrims. So each meter for in Masjid al-Haram for each meter is 1.5 Hajj. في عرفة كل متر تقريبا 0.16 meter. So it's very small area and condensed area. Okay, I'm gonna move this. So this is studies done by our colleague Mohammed al-Khlafi looking to the incidence and impact of stroke during Hajj. It was published in 2015 and show you the incidence is 8.9 per 100. They had like 186 cases. They were able to, and the thrombolysis rate was 2.7. And you know the standard thrombolysis rate is up to 15%. Okay, so this is a significant below the standard recommendation. Only thrombolizing 2.5% of eligible patient. I think it's significantly substandard. Okay, and they shows in their studies that one of the reasons not giving TBA, because the delay of the patient arrival to the hospital. Okay, most of the patients, because we know the crowdedness and the traffic, most of the patients they arrive at the hospital 6 or 7 hours later. There is a delay in the hospital itself because the hospital is jammed because of a lot of sickness and ICU patient and critical, so they don't triage acute stroke patient as maybe level 1 emergency, okay? So there was significant barrier of treating acute stroke in Hajj, okay? And that's the reason, and this is their workflow in Hajj. So the patient, when he gets a stroke, they dispatch him by the Gulf Cord, then he go to the hospital. Sometimes the hospital, they don't have CT scan, so they transfer him, second transfer to another hospital. Once he reached to the hospital with the CT scan, they contact the strokeologist and the neurologist. Sometimes they are on site, sometimes they are telestroke. And so it's very challenging of treating those patients. So due to many accessibility and mobility, this type of treatment is very difficult due to traffic, crowded, multiple checkpoint. And if you go to Hajj during Nafra from Arafah to Mina, they have hundreds of checkpoints. And even if you have an ambulance, sometimes you cannot go through, okay? They're closing the road. And we remember when we were in Mecca, Masjid al-Haram, and we want to mobilize the mobile stroke to Arafah, one day before Arafah, and we went there on 8th. Arafah is 9, right? They wouldn't let us in. We waited 7 hours to get permission from each one because they have different checkpoint and different authority controlling the route and the traffic. Patient baselines also they are at risk, and you know, with the mass gathering they have dehydration, sleep deprivations, and language barrier. This is a very interesting statement from Dr. Mike Hill. Dr. Mike Hill is one of the stroke figure from Calgary. He's our mentor and teacher. He said we cannot expect the patient disease biology to match our system because the time window for treatment of stroke is short. We must match our system to the biology of the disease. There is a lot of evidence of mobile stroke worldwide. Germany, India, they implemented the mobile stroke, and a lot of data that shows if you treat your patient on site and you dispatch them, they have better outcome if you treat them in the hospital. I'm not going to go on that in details. So in align with the Saudi national visions and missions and public health, we decided to try the mobile stroke in Hajj, and our goal to have timely triage, timely stabilizations, and timely treatment, and auditing and monitoring, and then improving and transformations. So this is our mobile stroke. It's a very large unit. It has a CT scan inside with the CT perfusions and all requirement. It has all the card and the medication that we need. PB medications, anticoagulations, irreversible of bleeding, BCC, vitamin K, antivans, metoclophramides. We have critical care trained stroke nurse with ACLS on the mobile stroke. We have a paramedic, we have a CT scan tech, and we have on-site vascular strokeologists on-site. So we moved there on 7th, and we covered by the way, we moved before that. We were there from 2nd of Hajj at Mecca. So from 2nd, we parked the mobile stroke in Al-Masjid al-Haram, just in front of the ER of small hospital called Masjid al-Mashair. Okay? This is our mobile stroke parked in the middle of the Al-Masjid al-Haram. And we parked there till 8, then we moved from 8 to Arafah. Dr. Muhammad, he was with us there, and he was a great help. And we moved to Arafah 9th, then we came back on 10th back to Masjid al-Haram. This is our parking in Arafah, in front of the main hospital in Arafah, just close to Jabal al-Rahma. Then we went back to Masjid al-Haram. 24-hour coverage when we were there. Strokeologists, we had 2 shifts, 12 hours for strokeologists and for other teams. So what was the workflow? The patient will show up at the in the ER, there in the Masjid al-Mashaa'ir. Once they think it's a stroke, immediately they will notify us. We are just in front of the ER. We go, we escort the patient, we take him and we put him in the mobile stroke, and we assess him while he's in the CT scan. Immediate assessment, immediate image, immediate CT perfusions, and CT angiogram. Okay. Then we decide if the patient has a stroke, we give him thrombolytic. If he has a large visual occlusion, we dispatch him to the nearest comprehensive. So we have King Abdullah Hospital, was just 20 kilo from us. They have the endovascular capable centers. We do the point of care lab, CT angios. As you know, 170 nationalities, so there was a lot of language barrier, and this was launched by Ministry of Hajj. They launched ChatGPT translators for all language. We were able to translate any Hajj who comes with difficulty in communications, and then we examine the patient. We do all full imaging. Then we decide whether the patient needs endovascular or thrombolytic. Okay, I'm going to move quickly for that because of the time. Then we dispatch the patient to. So this is our patient dispatch. Either if the patient has disabling stroke, minor, does not require thrombolysis or mechanical, we send him to a primary, secondary hospital with the stroke service. If he has large visual occlusions, we refer them to King Abdullah Medical City. If the patient has, we call it stroke mimickers, we send them back to the ER in the same hospital, Mashaa'ir. If he has disabling stroke with thrombolysis, we give thrombolysis on the mobile stroke unit. I'm gonna move. معي وقت ولا خلاص؟ ولا we're behind? طيب خلاص. So this is just going to give you an example. This is a patient who walked in الساعة 59, and time from ER to CT scan 7 minutes. We've done it in 7 minutes. Okay, and this is, you cannot do it in anywhere except in mobile stroke. You cannot do time from door to CT scan in 7 minutes. Okay. And this is tell you the beauty of mobile stroke. We've done the CT scan in 7 minutes, and sorry, just go. This is the Hajjaj in Arafah. We parked just in Masjid Rahma, next to Jabal al-Rahma. There was many cases of ICH, many cases occlusions that we transferred, some mimickers and some syncope. We've seen, this is our data, 28 patients. We gave TBA, some of them they went into vascular treatment. And this is our number. I'm just going to skip that. This is the percentage of patients we've seen. 28% of the patients, they were ischemic stroke, some of them syncope, confusion, seizures, and migraine. So I'll show you our thrombolysis rate went up from 2.7 to 27%, which is super excellent. It's just, above the standard, which is 15%. So just tell you how important you triage and treat the patient just on site, okay? Medium times to mobile stroke to CT scans, all exceptional number. I'm just going to skip that. And I'll skip that. So our mobile stroke experience in Hajj, it reduced the burden of health system, advanced accurate and timely triaging, it's more than a stroke unit, it was a neurology assessment unit. There was a lot of challenges on the patient and the catchment area, but it was I think we thought this was an pilot project for future transformation bidillah, and we're planning inshallah to go on Ramadan this year. We'll park it on Masjid al-Haram for the whole month and during Hajj. I want to show you just last one. This is a real story for Hajj that we came today.
Je suis venu avec le pèlerinage là, pour la première fois. Bon, en tout ce que je peux comprendre, comme je ne suis pas médecin, je ne sais pas s'il y a d'autres. Maintenant là, le moment là.
هذه الحالة احضرت لمستشفى الحرم عن طريق الفرق المتنقلة، واحضرت لطوارئ مستشفى الحرم. تم معاينة الحالة من قبل المختصين بعد اكتشاف وجود جلطة حادة في الدماغ. لأول مرة نقل المريض للعربة المتخصصة للسكتات الدماغية. أدخل المريض بالعربة، تم عمل الأشعة اللازمة، تم إعطاء المريض العلاج اللازم.
Je n'ai pas de problème, comme je n'ai aucun problème maintenant là. Si je vais au pèlerinage, c'est fini. Ce que vous êtes, il n'y a pas d'autres comme vous. Il y a beaucoup de services. Qui peut faire ça, si ça peut Dieu? Après Dieu, c'est vous. Comme si je suis comme si en enfance comme ça. Je dis que si je vais au pèlerinage de demain, je n'ai aucun problème. Mais très bien, moi que vous-même, vous écrivez ce que vous savez être le meilleur à mon nom. Deuxièmement, si je retourne en Guinée, je retrouverai mes enfants, je retrouverai mes petits-enfants. Ça, c'est. Troisième impression, au contraire, c'est la première question.
So, in conclusion, streaming the whole care system, positioning awareness for acute stroke by MS, ER in Fleet Hospital, pilgrims in Ramadan, and changing the regulations in authority. This is when slide الأخيرة? لا, just a slide, one slide. آخر slide. محمد آخر سلايد. على العموم هي سلايد هذه فيها the whole team. I want to thank you. طبعا this is a teamwork, not single, and even not King Faisal hospital work. It's a Ministry of Health authority regulations with other health sectors. Security and Rijal al-Aman, and everyone was contributing to this. We think a transformation. Thank you so much.
Thank you very much, Dr. Nasser, for your rich, informative talk. I do believe that we don't have much of time. We open the floor now for certain questions, very quick, for our respected audience. And respected speakers, if you have very specific certain questions, because sorry we run out of time. Any questions? Yes, please.
Thank you for all the speakers. As you mentioned, Dr. Muhammad, the latest track and Dr. Nasser explained comprehensively about
of stroke. Do you think the time now for scientific perfusion is at the end? Do we still need it, or there is some sort of reliability on CT perfusion?
Yeah, I think it is a debated topic nowadays. CT perfusion has some advantage, especially to exclude stroke memory. So I know the recent study, large core stroke, they use most of the study CT and was positive. So why we need CT perfusion? But I think in TBA, maybe still we need CT perfusion for patient selection. And even in thrombectomy, if we look back to the result, the function outcome in large core stroke, and to compare it with the diffuse and on study, the benefit is not the same. The outcome, it is higher, especially in first three, من 0 to 3 MRS score, it is higher in patient with CT perfusion mismatch compared patient without mismatch. The risk of hemorrhage also higher in patient without significant CT mismatch. I think CT still has a role in acute stroke. I know the recent study which used the CT without perfusion also can help a lot, especially in peripheral hospital where the CT perfusion is not available. I think it is difficult. I think what we have, what data we have, we cannot conclude. Still we need CT perfusion or not. There is still advantage of CT perfusion.
Okay, thank you very much, Dr. Muhammad, Dr. Nasser, and Professor Chowdhury. Lastly, we have about 15 minutes talk regarding a scientific paper that we're going to be presented by Dr. Arwa Al-Hamid, nursing specialist for stroke patients at King Abdulaziz Medical City National Guard Hospital. Please.
Assalamu alaikum jami'an. Good afternoon, everyone. My name is Arwa Al-Hamid. I'm working as a stroke nurse educator at King Abdulaziz Medical City in Riyadh. Thank you for this opportunity to share my study project. I will be presenting the study project with title Relationship between Stroke Patient Knowledge and Emergency Arrival Time among Adult Stroke Patients. Nothing to disclose. As we know, the stroke is a leading cause of morbidity and mortality. Early arrival time is critical, especially with the first 4.5 hours. However, delays are still remain common due to limited patient knowledge. This study aimed to assess the level of adult stroke patient knowledge and its impact on their emergency arrival time. For our methodology, data were collected between 2024 to 2025 with a total sample of patient 546. We conduct a cross-sectional study among adult stroke patients. Arrival time was classified as early and delayed based on the first 4.5 hours. Here in our, based on our finding, the patient with the high stroke knowledge were significantly more likely to arrive early to ER. However, awareness about TBA tissue plasminogen activator remained low with 22%. The main reason for this delay were not system related, but it's patient-related. About 78% of delays were due to the lack of awareness of TBA, tissue plasminogen activator, or interpretation of stroke sign and symptoms. In conclusion, stroke patient knowledge has significant impact on early arrival time. Patient awareness of thrombolysis therapy remain inadequate. Therefore, public education plays a crucial role in improving early stroke recognition and response. Mainly we are focusing about is enhancing public awareness to improve stroke outcome. Because in stroke care, time truly means a brain. And this is our references, and thank you for your attention.
في ختام الجلسة الثانية من اليوم الأول لهذا المؤتمر، شكرا للمتحدثين في الجلسة الثانية الدكتور محمد العتيبي والدكتور ناصر بن ضيف الله العتيبي، وأيضا الأستاذ الدكتور هارون فياض شودري، وأيضا الأستاذ الدكتور عبد العزيز محمد العثمان، وكل الشكر لمدير الجلسة الدكتور فيصل بن سعود الكثيري. الآن في ختام هذه الجلسة ندعوكم لتناول طعام الغداء، والسلام عليكم ورحمة الله وبركاته.